All right. As mentioned, this is the first time we're doing this, so I think we're good to go. We've got the recording devices on. So just coming back, so Linda and I thought it'd be a great way to kick off the session by highlighting some of the work that we've done, as well as sharing with you some of the national initiatives that need to be done when we talk about opiate use and medication safety. So the objectives, again, is to increase your awareness. As I was driving in, I feel like every morning I drive into work, there's something on NPR about opiate use, right? A national public health crisis. Pennsylvania just called, a state of emergency. So there's so much attention being given. And I feel that, and when we talked about this at the Lamy Center, we felt like a lot of attention is given to a younger population, but often again, our older population are being forgotten when we look at some of the guidelines that are being developed, some of the initiatives that are being done. And we really feel very strongly that we need to find a balance here as practitioners, as researchers, as advocates for our patients and other initiatives to help older adults ensure that we're adequately treating pain and not causing more distress. So we'll highlight some of those initiatives and hopefully, again, not just sitting in this classroom today, but I've got your email tapping into you for initiatives and opportunities for the future as well. So I like to start with a case. What keeps me grounded as a person and as a practitioner is my patients, right? And so I work in a primary care setting, ambulatory care. I've worked in nursing homes. I still do some work in nursing homes and assisted livings, but primarily I'm now in the ambulatory care space. And I'm finding, like many of us, our older adults are navigating a very complex problem, right? Access to medications, access to care. So we have a relationship with our emergency department, and I think some of you may as well. So they referred this individual, and this could be someone referred to your practice, and she had 4 falls in the last 6 weeks, right? And the emergency department is worried about her use of medications. No brainer. Look at her medications, right? Blood pressure medications and a multitude of different medications for pain, gabapentin, oxycodone, naproxen in terms of self-treatment. And then for her psych, because she's depressed, anxious, and she's on aripiprazole and alprazolam. So these are just basically not that many medications, but some really high-risk medications. So what we're hoping to do with this program is, where do you start when treating? So she's coming in, she's obviously not feeling like her pain's being adequately managed, and she's also concerned, and the team's concerned because she keeps on falling. So, right, high-risk medications, problems maybe not being adequately addressed. So we'll kind of talk through this, through some of the seminars and visit it back, but this is when Linda comes in.
Yeah, but wait, there is an elephant in the room. And I know this is a talk about pain management, and it is really, first and foremost, we know very little about treating pain adequately in older adults, but we also have to consider the other side, and those are the benefits. And that's the elephant in the room. We don't talk a lot about substance use and substance use disorders in older adults generally. I think in some ways it's because, well, grandma's 84 or 82 in NJ's case. She's 84. We don't need to deal with it. She's going to die soon anyway. And that's a lot of the sort of common thought that has gone around in practice for a long, long time. I wouldn't say in geriatric practice, at least most of us probably think about it a little better than most people. But even in research, until lately, there's been absolutely no interest in substance use disorders in older adults. And I'm very pleased, actually, that the NIH came out with a request for applications that finally looked at older adults and marijuana and opioid use. So what I want to talk a little bit about, just to get this out on the table, and then we can go back to pain, but always keep in the back of your mind some of the things that are going on. Some of the need to balance the risk and the benefits of any analgesic treatment or any treatment for pain, but particularly those that of the opioids and some of the sedatives as well that might have some impact on pain management. And if I sound a little sniffly, it's because I'm one of the few people who got the benefit of a $5 Target gift card from the flu vaccine, and that was the only benefit I got. It was. I'm glad I didn't have to pay for that flu vaccine. That did not work. I'm not sick now. I'm not contagious. That's what I keep telling myself. So I'm standing here before you, but I'm not contagious. I just want to tell you I'm just a little blah. So I do a lot of work in substance use disorders, and I really have focused almost all of my attention on older adults and disabled Medicare beneficiaries. I do a lot of work for the state, but when we do prevention programs, we're really focusing on the young people. Let's not let those teenagers, get into those opioids or marijuana or cigarettes or whatever. I'm really interested in the medical use and then what becomes problem use of opioids, and have been doing this for a long time. What we do know about opioids, and this is the general populations, is that 3 out of 4 prescription drug overdoses does involve some opioids. So about 75% of all prescription drug overdoses, because a lot of times overdoses are intentional. They're swiped through the medicine cabinet to find out what's there. I want to end my life, or I'm just wanting to get high. But we've seen a huge increase in prescription opioids. Now, lately it has stabilized, both in terms of use and overdose deaths, which is a wonderful thing. But we've seen that the use of the overall opioid overdose and deaths have increased because of the stuff that's illicit, the heroin, the sufentanil, the carfentanil, all that good stuff. The FDA has recognized that there's a problem with prescription opioids and has put out multiple black box warnings. We won't talk now about whether these black box warnings are effective or not, but there is concern. You can see that it's here. In particular, in 2016, there was a black box warning put out saying older people should avoid the use of benzodiazepines and opioids, including those products that you find in cough and cold medications. So what do we know about what's going on in older adults? Well, essentially, we don't know that much. There's not a lot of data collected on older adults. There's not a lot of data collected on older adults. And once again, it's been not a big research priority. We do know, though, based on some reports, that the growth in prescription opioid use has been fastest among Medicare beneficiaries. And when I talk about Medicare beneficiaries, I'm talking about the disabled and older adults. Because we've looked at Medicare on the whole. But we do know that in 2015, 30%, which is about 12 million beneficiaries, received at least one opioid prescription. We also know that spending on prescription opioids increased 165% from 2006 to 2015. And that's on the entire Medicare beneficiary population. And even though there's been a big increase in the prescription opioid use in the total Medicare population, much of that has been driven by the younger folks, the disabled, who have even more often extreme and complex medical needs than older adults. But we did see a 9-fold increase in the 6 years in those who are 65 and older. So opioids are quite prevalent in the older adult population. And it's not just occasional use, maybe a short-term use for some sort of bone fracture, but really long-term use. And for here, long-term use is anything greater than 3 months. So we saw an increase, almost a doubling. 2007, pardon? Yeah, it's a lot. So that's almost more than 1 in 20, almost 1 in 10 older adults had long-term use, chronic use of prescription opioids. And as I mentioned with the black box warning, concomitant use of opioids with other substances is particularly problematic in older adults. Older adults, as you know, metabolize differently, not as efficiently. They have other complex problems. So we end up having a problem of polypharmacy often. And also smaller doses or lower doses will often cause problems more quickly in an older adult who might be frail. So we found out in 2015 that almost 30% of Part D prescription, Part D Medicare beneficiaries, those who had Part D benefits, who used an opioid prescription, also at the same time used at least one sedative hypnotic. And by sedative hypnotic, we're talking about the benzodiazepines, we're talking about barbiturates, which are rarely used, but also your Z drugs, your sleep medications, your Zalopon, your Ambien, all that good stuff. What we do know about this concomitant use, and it's actually the single use of these substances as well, but really the concomitant use of these will really further cognitive decline in older adults, puts them at higher risk for falls and traumatic brain injury, which might be related to falls or other accidents. Of course, there's the problem of dependence, of abuse and dependence, and then finally overdose, both fatal and non-fatal. What we don't really have a firm understanding of how many older adults have what we would call a substance use diagnosis, which would be a DSM-4, now a DSM-5 type of abuse or dependent criteria that meet DSM criteria for abuse and or dependence. But SAMHSA did some projections some time ago and came to the conclusion that older adults who are 50 and older with a substance use disorder would probably double by 2020, which is just in a couple of years now. Lord, I remember I saw those statistics. Oh, 2020, that's forever. But it's like, it's next week. It's going to double to almost 5.7 million. Now, part of that's because people who are 50 and older are taking up more of the population. And there's also a lot of cohort effects with those baby boomers. But this is a group of people for whom the substance use treatment is just, community is simply not equipped to deal with. So generally, this sounds like a lot of information, and I guess it is, but it doesn't really reveal a whole lot of what we know about older adults who have substance use problems or who may be at risk for substance use problems. We have all these other questions, like what are the characteristics of older adults who use and may possibly abuse or have problematic use of prescription medication? And what are some of the characteristics that we might find associated in older people with substance use disorder? We know very little about outcomes in older adults other than fatal overdose. And the only reason we know those is because the National Vital Statistics system collects that information. We can do, crosstabs, and the CDC reports it in their MMWR. And there's lots of reasons for this scant research. I mentioned most of them before about the stigma, and we don't care, and we think prevention starts early, and what good is prevention when you're talking about an older population? But really, one of the biggest problems is that for years, we could not get information on substance use disorders in our data on Medicare and Medicaid people because of something called the data, it was patient privacy, but every other condition can be reported, but not substance use disorders. So we did not have information on data that was federally collected on individuals who had substance use disorders because those diagnoses did not exist. If a claim had a substance use diagnosis, it was stripped from the data that was publicly available to researchers and even privately available. So we have no idea what the infrastructure of the problem, the epidemiology. Until recently, this was overturned this past year. And so we had some data early on from 2006, from 2009 of the Medicare data that had some of this, what we call unredacted data. So we started doing some analyses with it to just start to get a snapshot of what substance use disorders look like in older adults and some of the conditions that are associated with it. So our first objective was to look at, to try to improve understanding of Medicare beneficiaries that might have a substance use disorder diagnosis in their claims by looking at patterns of opioid and sedative hypnotic use. We were interested in both of these together because they are such a problem in this population. Excuse me. And essentially, we want to look at the overlap of substance use disorders, pain, and mental illness diagnoses, which literature suggests are big comorbid conditions associated with SUD, and also pretty prevalent in older adults. And our second objective was to examine relationships between substance use disorders, pain, and mental illness, and opioid sedative use with opioid overdose hospitalization. So I'm just going to give you very quick information. This stuff is now being developed into a manuscript, actually a couple of manuscripts, and we've got more information if you want it. But we just think it's something, as you go into your practice to think about, do you see some of this, or is this something you should consider as you're dealing with management of pain in some of your patients? But first, keep calm. I don't have a lot of statistics. I can't deal with statistics much before 10 o'clock in the morning anyways. But it's just really to give you a snapshot of what's going on. So we use something called the Chronic Condition Data Warehouse, which is essentially Medicare data. It includes all your inpatient, your outpatient, and your prescription drug claims from Part D. These are the inclusion criteria. The exclusion criteria, essentially, we want to avoid people who are in hospice because they're going to look, and they do look very different from individuals who are not in hospice or end of life. And for our second objective, we looked at people going forward from 2006 we looked at 2008 and 2009, just wanted to look at their medication use patterns for the first aim and their diagnoses. But then for the second objective, we really wanted to look at those individuals who suffered some sort of overdose event, hospital event. It could be emergency department or inpatient, and it could have been fatal or non-fatal, and then look backwards to see did they have a substance use diagnosis? Did they receive a prescription opioid? That sort of thing. So these are just some of the ways we defined what we use to define substance use disorder, mental illness, and pain. And I'm keeping an eye on the clock, so I'm just going to have you look at this, but you can look at this at your leisure. We were interested in all opioids, full and partial agonist. And these are some of the comorbidities we're particularly interested in. Alzheimer's disease, as you know, cognitive function really has a big role to play in terms of both demonstration of symptoms of pain, of psychiatric illness, et cetera. So we're very interested in that population. And what we found was of almost of over 1 million people, almost 1.25 million people, we had about 24,000 that had any indication of a substance use disorder. And that, so it's and most of these were male. You know, those who had substance use disorders, about 60% were male. We found that those with a substance use disorder, the individuals who were Black, has slightly higher prevalence, well, twice as much as whites. Twice as much as those Blacks who had a substance use disorder were twice as likely to have a substance use disorder than not. And then we looked at age, and that's actually, don't even bother with that because that was a continuous variable. If you look here, you see that it's really highly populated in those who are disabled under age 65. We saw that there's some comorbidities that were particularly associated with substance use disorder, and that's that first column. And that includes chronic obstructive pulmonary disease, which we've actually been doing a lot of work in separately because we have found in other work looking at COPD and depression, opioid use and benzodiazepine use is really high in this population. They're both respiratory depressants, and people with COPD tend not to be able to breathe. So it's all very interesting. My mom is my case example on that. And then, of course, Alzheimer's disease and HIV, which, you know, a lot of people think of HIV, older adults, forget it, but it's actually becoming, we manage HIV, so people are aging into older adulthood with HIV. And here you can see that, that there's a high association of both mental illness and pain conditions in folks with SUD, much higher than those without substance use disorders. And this slide just shows what happened when we looked at opioid overdose hospitalization, fatal and non-fatal, and prescription opioid use. And we were able to look at the type of substance use disorder. The yellow ones are the opioid overdose rates in individuals who had this particular substance use disorder. And then the numbers on the top were actually those who had any evidence of having an opioid among those people who had a hospital event that was some sort of overdose. And you can see, obviously, that the bar over there says opioid substance use disorder. You've got a high use of having any sort of substance use disorder as well as high use of opioids. It makes sense. But we were curious because with these diagnostic codes, we can sort of parse out the types of substance use problems individuals have. Often individuals don't have one sort of substance use disorder, though. They might have an opioid one and an alcohol one. This is just what comes into the hospital and what was the first thing marked. But I will note that no one has ever seen this information. This information has just not been available anywhere in the literature. So it's something to start thinking about. And this is across the nation as well, which is very important. And then we wanted to look at, as I said before, we looked at the total events, hospital events in 2009 that involved an opioid that was an overdose, fatal or non-fatal. And we had a total of 1,225 events. This is not 100%. This is just 5% of the older adults. So if you multiply that by 1.05, you'll get many more. 100.5, you'll have a lot more. 105, you'll have a lot more events. But this is just 5% of the Medicare population. So we had over 1,000 events. And you can see that that the majority of folks had no problem, no record of abuse or a substance use disorder, but there are those that did. And that some of them even had a prior overdose. About 27 individuals who came in had a prior substance use disorder. I had a prior opioid overdose. So that could be a big flag or trigger. Have you ever been admitted to the hospital for an overdose? And that would be something to suggest that predictive of the next one. And this is just, very briefly, sort of what we're seeing with individuals, those individuals who had a substance use diagnosis prior to the opioid overdose in 2009. That was 186 people, which was more than 10% of all the hospital overdose events we had. But almost half had more than one substance use disorder. As I said, many individuals present with more than one. Alcohol was a problem for 36%. Illicit substance use as well was, which means, it could be marijuana, it could have been heroin, could have been cocaine. Sedative use, prescription and otherwise. Then there's the opioids, obviously, stimulants, and then general not specified. It's important to note that of these 186 individuals who came in, almost 70% had both a mental illness and a pain disorder diagnosis sometime in the year prior to their coming to the hospital. So I just want to briefly just provide some estimates of a national sample of Medicare beneficiaries. We're doing more involved information, but these are just some of the things you should look for in your practice. I think that we're going to see more and more substance use disorders in this population. It's something to think about as we go forward. I think you're up next. So of course we ask, how do we get to this place? And Nikki will continue from there. I'm going to go sit down.
Yeah, thanks, Linda. All right. So as I mentioned, we wanted to highlight what's happening nationally. So how did we get here? And I think we can all kind of self-reflect depending on where you are in your career, right? For some of us who've been around for some period of time, the fifth vital sign. So everyone's getting a pain assessment, and that propagated finding a problem, treating a problem. And even among some of the organizations we've worked with the American Geriatric Society, when we've tried to offset the use of one medication like our non-steroidals, we might have encouraged the use of other medications like our opioids. And so I think, and then we tend to be a society where we want a pill for every ill, and our patients demand it. So there's a lot of drivers of this public health crisis, as we stated at the beginning. And I think as providers, we're kind of caught in that conundrum because now we're being scrutinized on how we're using these medications and what's justifying the use of these medications. So, so safety at the foremost, patient-centered care are some of the highlights you'll hear today. So what can we do as a university setting, as practitioners, as healthcare system providers? Well, what I've posted for you on the website is the National Academies of Medicine, Sciences, and Engineering, primarily medicine, came out with strategies for health professional organizations. And I know I don't have a lot of time because I want to highlight a couple other things. I think one of the first imperatives was to establish comprehensive pain education materials. So we're taking a stab at that with a focus on older adults. So from this program today, we will be posting materials that we have, other materials that have come up. I've had our interns pull some apps that'll help you. There's on and enduring programs through the Centers for Disease Control. CDC has a series of education. And then by educating you, you'll educate others to be better equipped to care for our patients, especially those older patients. And then to think about what can we do on a public health perspective. So again, I think we could spend quite a period of time, right, Dr. Mcpherson, about the CDC guidelines and recommendations and the debate that ensures regarding how they've looked at older adults. But it really has opened up the discussion both in terms of drug development, drug use, drug monitoring, and really putting the burden on the system of how we're engaging our patients in those discussions. So you're going to hear Dr. Doberman and Dr. Resnick talking about those goals, talking about assessment, discussing risk and benefits. And I think as more data comes out in those long-term risks, especially with chronic care, we'll have to have a better understanding there. How many of you, just by a show of hands, are actually using CRISP data routinely in your practice with PDMP? Okay, so I think we've got some work to be done there. I know for some of our pharmacists, depending where they practice, access to the complete CRISP data set has been an issue. And I know as pharmacists, though, at the minimum, we should be having access to the prescription drug monitoring program data. And again, I know Dr. Simone Wastel has done a lot of work in this area. Urine drug testing came out of these guidelines. And I know that depending on the practice settings and talking with some of our colleagues in medicine, how they're dealing with the monitoring aspect, the drug monitoring, the drug testing. you saw the black box warning come out on the concomitant use, and I think it's staggering from national claims data of what we know, the concomitant use of opiates and benzodiazepine, and you heard that elephant in the room. So I can't say I have the answers to everything, but I think we need to start having some hard conversation, and I think the academies and other organizations are trying to lead that. So again, lots of tools out there by the CDC and others. How many of you have actually saw the mobile app by the CDC? Yeah, if not, it's free, downloadable. I find it pretty useful with some of the resources that are out there. Again, we don't have a lot of time. We respect that. So use the programs and the materials that are out there already that are not promotional for any sort of pharmaceutical product or such. So there's a lot of scrutiny there as well. Now, I know we're all under that kind of quality, right, umbrella, and I know some of you are coming from healthcare systems. So those of you who follow measures, and I do, I think it's pretty interesting, know that just in 2018, they came out with some additional measures. And there's been some blogging on the NCQA site that actually I referenced here on how these measures will hopefully help you as practitioners to alert to those that at greatest risk. So they're trying to get those that are using multiple providers, using multiple pharmacies on higher doses and the interaction between those. And they share stories of deaths of both younger and older individuals because of not having safety nets in place. So just as you shared your hands with raising them of if you're using the data that you have access to that may or may not be integrated in your workflow, hopefully this additional work will help alert systems to really identify those at some of the greatest risk. Now, carve out that our health systems, when we look at measure development, these are 18 or older. And so there's some discussion on there should be ones looking at young or older adults a little bit differently. And I was fortunate just recently to be appointed to NCQA's GMAP. So I bring that pharmacy perspective in. How do we look at claims data? How do we look at doses? How do we look at multiple pharmacies? And how do we make our pharmacists have this access as well? So a lot more work to be done there. So take-home chronic pain management, the team's going to talk about it, is challenging. We need to work through different tactics. We need to work as a team. There's lots of resources out there to help us. And I just want to bring it back to the case of NJ, right? So started with the case, want to end with the case. As Linda said, the elephant in the room with this particular case, we developed a pain contract. She came to our team, became engaged in a pain contract. We slowly cut back on her alprazolam use. We slowly cut back on her pain medication use. We have a great non-pharmacologic team approach. We work with Dr. Hogan's with some non-pharm approaches, and we try to streamline her medications, both pharmacologically and non-pharmacologically. But I bring in this case because the elephant in the room was indeed the case. She decided, well, even though we cut back on medicines, she still really liked her medicines. And so she didn't follow through with her contract. She left our practice, and now she's back in the emergency department regularly. And I bring that up because sometimes our patients make choices that we can't control. She's competent, she's older, but the concern here is what can we do, to try to ensure that she's not overdosing and ending up in the hospital. So what kind of safety place can we put in place? So this has been a challenge for me personally because you always want to make our patients safe, right? And unfortunately with NJ, we tried, we succeeded, we reduced the emergency rooms and hospitalizations, but then she decided to continue to obtain the resources. And again, PDMP was very insightful for us to be able to track because she tells us about what we know, but there was a lot of things we didn't know. And oxycodone was just the tip of the iceberg because she also had tramadol, fentanyl, and other narcotics that she was getting from other prescribers. So with that, I'm going to turn this over to Dr. Doberman. Those of you who know me know I like to stay on an agenda. So we're going to try to keep us on track. And so our next presenter is Dr. Doberman. And I've got your slides here. And really excited to have you join us today. So thank you. There we go. And then you can do either page down or here. That's a pointer. And then there's just, if you want to go that way. Yeah. Great. Thank you.
Thank you to the Lamy Center for inviting me to speak today. I'm going to talk about establishing strategies for really basically negotiating a pain contract with patients and even just patient-centered care. I have no disclosures. So this is a hypothetical case, but if we have Judy, who's a 69-year-old widow, so the young end of our patient, with osteoarthritis, cardiomyopathy, CHF, with an ejection fraction of 30%, and depression. So she comes to your clinic for acute on chronic back pain after helping a friend move. When she was seen at an urgent care center 2 days prior, she was given hydrocodone acetaminophen and told that she may have had a compression fracture. So Judy normally sees your partner. You only have what's in the EMR when you see her and what she tells you. And both the EMR and Judy say she does yoga regularly, she swims, she goes to a chiropractor. So that sounds very healthy, self-maintenance for somebody that may have chronic pain. She did say she was fearful of trying either of the drugs that were given her because she has a weak heart and she has had issues with things in the past. Her medication list is there: Cineprol, Toprol, sertraline for her depression, Lasix furosemide, and a multivitamin. So we know that just in general, there's 4 very broad classes. If we had to just, if you're a lumper or a splitter, kind of lump all the medications into 4 broad classes for pain management. We know there's the non-steroidal agents, the antidepressant agents, the anticonvulsant agents, and then the opioids. And for older adults, each class can have a pro or con depending on your list of comorbidities. So for our patient Judy, the non-steroidals with her congestive heart failure have relative contraindication. The antidepressant, she's already on an antidepressant, so we might get higher risk of serotonin syndrome, for example. The anticonvulsants have their own set of side effects, but also their time horizon to benefit for somebody who has an acute on chronic problem is less than ideal. And then we're back at opioids. So as a group, what would be your next step in helping Judy, who's in your office? Mumble, mumble, I didn't get it. Non-pharmacologic. So my suggestion for me as a provider is I need more information. I think the historic dynamic, and that's what I really want to talk about today, the historic dynamic is, what is your pain score out of 10? And I need to move the needle on that, and I need to get on to the next patient. But how do we upend that in the new era of pain management? So what are my open-ended questions? Tell me more about what your challenge was with pain management in the past. What have you used in the past that have been helpful and not helpful? Tell me more about your concerns about these medications. Use of the open-ended questions is very helpful. It helps avoid assumptions. And when they've done time flow studies, using the open-ended question, actually, providers are not in the room that much longer. And when the patient gives the information, you actually get to the root of the problem much quicker. So when you say, tell me more about your concerns, says her cardiologist warned her about certain types of pain medicines, but she doesn't know which those are, so she chose just not to take anything the urgent care center gave her. That's actually good. And then she says she's actually an active member of AA and has been for 20 years. And she questions if any of these medicines will impact her sobriety, because she knows that's been talked about in group meetings. And she does tell you that she had misused prescription medicines following a knee replacement in her late 50s. Wow. And the way MRs are these days, that's kind of buried somewhere in a note on like screen 30, underneath. So, so how do we decide what is best for Judy? She's already doing a lot of non-pharmacologic. We may or may not have the images from the urgent care, which may or may not have a real compression drug. That's done in shared decision-making. So definition of shared decision-making is it's a process. It's not a one-time event. When clinicians and the patients work together to clarify and identify treatment decisions, management options, or self-management goals, such as we'd like to get your hemoglobin A1C down. What do you think about that? Do you think you can do that? And the information about options and outcomes is sort of bi-directional. As a physician, I know the medical literature, but the patient knows themselves. And I often say to patients, you have a doctorate in yourself. This represents a major shift in the provider-patient dynamics, where control and power is shared. When we describe shared decision-making about future decisions, it's advanced care planning. So the old dynamic is somebody says, you know, I don't think I can quit smoking. And then you, the doctor, the provider, you try to come up with the ideas, or you try to encourage them. The new dynamic is, why do you think that is? You know, what have you been trying? What concerns you most when you think about quitting? What barriers are there? And you try to have the patient come with their ideas for success. So shared decision-making is appropriate when there's more than one reasonable course of action, and for decisions that we say are preference sensitive, where the patient's preferences for outcome should be taken into account. So for somebody like Judy, one treatment might help one condition, but it might worsen another. So maybe a short course of opioids, it's going to put her at risk of reactivation of her substance use disorders. And that may be something we talk about if her pain gets really, really bad. But she has to be a participant in that. And maybe it means going to NA meetings. Shared decision-making is adding in all the information and me just not writing a prescription for Ultram or oxycodone and handing it to her. So treatments that have long-term benefits but short-term problems, multiple medications are probably one of the biggest ones in older adults, where the harms must be balanced with the comorbidities. So one of the other good communication strategies in this is to say, am I hearing you say, and kind of summarize what the patient says and repeat it back. We're trying to negotiate a shared agenda. Am I hearing you say you're concerned that any pain regimen that we choose not affect your sobriety, not re-trigger addiction, and be safe for your heart? Have I understood you correctly? The ask, tell, ask model that I know has been taught in a lot of other environments is a core component of shared decision making. The other thing to see here in shared decision making, what I wrote out on the slide, new things in pain management is not to just move the needle on a number, right? We're not just trying to get 10 down to 5. It's choose a functional outcome. So what is Judy not doing now that she wants to do? Or any other patient that comes to the office with a pain management complaint. I can't get out to church and back with ease. I can no longer do the food shopping. It's not, okay, and what is your pain score? It's, okay, let's make getting out to food shopping our goal. Choosing a functional goal is now a preferred method of having an endpoint, using an outcome measure. In other forms of end-of-life and palliative medicine, we often use milestones as well. So I want to be able to get to my grandson's graduation with ease. It's so painful, I can't get out of the house most days. But how can I just get to that graduation? Can we find a way for me? And that may be through physical therapy. That may be through assistive devices. So the key to shared decision-making is discussing the goals of care. And for each patient, their goals of care are different. For some people, it's curing their disease, living as long as possible. For other people, it's avoiding pain, avoiding debility, avoiding dependence on others. And as people live longer or they are challenged by goals, one thing that's important to note is the MOST, which is the medical orders for life-sustaining treatment. These are orders. These are not goals. And so many times people in the hospital, especially young doctors, will say, the patient's full code, therefore we must do, or probably people, and they're not equal. And so anytime a new decision arises, which is sensitive, we should again renegotiate the patient's goals for their outcome. There's actually some values history forms that you can administer to patients. A conversation project is wonderful as something to give patients when you're talking more about true life goals. I was taught in fellowship just to ask 3 questions to get to patients. We call them the magic questions. What's your greatest fear? What brings you joy and meaning? And what do you still hope to achieve? And we should direct your health care towards always achieving those goals. All of these values and goals help patients define what is meaning in their life, what makes living. And I think too often with older adults, we focused on having people have a good death or having, the sunset of their years. But these are, again, trying to flip that towards what makes living. And everybody knows this is Joan Rivers. She had actually written in her living will, and this is a quote from her daughter, that she specifically wanted to be able to go on stage for an hour and be funny. And so we all know that there was a mishap in her healthcare. She ended up being intubated, and her daughter ended up removing her from life support. She did that because she was guided not by an advance directive that talked about technology, but talked about this goal, this outcome. So how do we take that back to pain management? Here are Judy's goals, which we've now written down and we're going to negotiate with her. The prescriptions must not impact sobriety. They must not risk addiction. And they must be safe for her heart. She does want to avoid pain, but she's willing to trade this maybe for a little bit of alertness. But she has this functional outcome that she wants to be able to drive herself to pick up her grandson at the elementary school. So how do we make that happen? And I'm going to leave that open for, that's our care plan with Judy. So a different patient now, Edna, who's living in long-term care, who lacks capacity, but her goals are unknown because she can no longer tell us. So she's 95, COPD, chronic kidney disease, advanced dementia, osteoporosis. She had a hip fracture 3 months ago. She has survived the acute event. She has profound dysphagia. She needs pureed and the classic honey thickened liquids. And in the last 12 months, in addition to the hip fracture, she's been hospitalized 2 other times for urinary tract infections and pneumonias. She no longer recognizes her daughter. She's total care, except for she sometimes can self-feed with a spoon. She's become increasingly resistant to care and transfers in the last month. And she has not responded to non-pharmacologic interventions to make the transfers and care easier. That's often a sign that perhaps there's involved. This patient, by the description I've given you, is actually a hospice eligible patient, most likely. The daughter is worried, though, maybe the staff approached the daughter, we'd like to start a pain medicine for your mother. We're worried that sometimes when we try to bathe her, she's resistant to us moving her and manipulating her legs and arms because we think her osteoporosis, maybe that hip is hurting. But the daughter is resistant. She's worried that pain medicine will worsen mother's dementia and might dull mother's mind more. And again, there's no restrictions on treatment. She's full code. These things don't necessarily equate, true and unrelated, as we say. But does the daughter truly understand mom's trajectory in life? Does she understand mom's prognosis? So when it comes to patients with dementia, decision-making is often more challenging because it's done through the surrogate. And decision-making often differs with the stage of the disease, mild, moderate, or severe. Many times, patients have written living wills early on in their care. And the Alzheimer's Association actually has a quote saying that aggressive medical treatment in and of itself may feel like torture to patients because they may be unfamiliar with a phlebotomist coming or even going out to a doctor's office from their nursing home. That's a totally unknown environment, and that in and of itself may induce anxiety, just not understanding the intentions. So how do we assist her daughter in helping us with a care plan? So again, we have shared decision-making. So it's a balance. It's not paternalism. It's not full autonomy. It's both. So information is that key. So does the daughter have the same information that the staff at the nursing home, that the providers have? Does the family understand the prognosis? Do they understand the typical disease course? And prognosis is not just life expectancy. Sometimes for somebody like Judy in our first case, what is her prognosis for recovery if that really is a compression fracture? So sometimes prognosis is recovery from an illness, etc. And in this case, we don't necessarily know the patient's goals. Would her daughter's goals possibly differ if she knew that mother had no more prognosis for functional recovery? If she knew the trajectory of dementia at this point in terms of maintenance of cognition, and if she had more education about the stage mother is in with that advanced dementia. Whenever there's multimorbidity with dementia as one of the diseases, that tends to pull as one of the strongest comorbidities, making delirium a much higher risk. They've actually shown in studies of cancer patients with breast, colon, and prostate, if patients have dementia as well, they have actually a much shorter prognosis with all those than age-matched peers. So the American Geriatric Society has a wonderful, wonderful article. I think Nicole was on one of the panel developing it, talking about how do we handle multimorbidity in older adults. And they developed this approach to evaluating and managing all this whole group of illnesses. They came up with 5 guiding principles, and they sort of have this flow algorithm, which starts with, again, with shared decision-making. What is the patient's primary concern or the surrogate? And then look at a complete review of the care plan, identifying that specific aspect, keeping it in mind what the patient really wants us to focus on. Thinking about patient preferences, we always have those patients say, if I cannot go back to the hospital again, that would be really great. Is there any evidence? Most studies focus just on one disease. Many research studies don't include patients over the age of 70. Is there any evidence that we can apply? And then looking at prognosis, either for functional recovery, an outcome, or life expectancy. And looking at interactions, drug-drug, drug-disease, disease-disease. And then trying to work with the patient and family to educate them and enlist, because it's not informed consent without information. So these are the general 5 domains: assessing patient preference, interpreting what is often limited evidence, trying to discuss prognosis with the patient so that they are aware, preservation of function, remaining life expectancy, quality of life. What would somebody's quality of life be with and without an operation, for example? And then the clinical feasibility. How feasible is it to perform some procedures? So I'm not going to give you the answers to any of the cases because I think that they are debatable. They're preference-sensitive cases. So to do another, and the last case is Joe. So this is a case in an urgent environment in the hospital. Joe's 81 with Parkinson's disease, early Parkinson's. He has coronary artery disease and COPD, and he wears home oxygen. And he sustains a fall, trips over the tubing, and has a hip fracture. So he is high risk for surgery from a cardiac and a respiratory standpoint. There's a new method that is being taught to surgeons in about the last 2 years. How do they do informed consent? Right? Usually say, you could bleed, you could get an infection, your wound could do his. But that is not informed consent to the totality of events that happens to older adults, right? You could end up in a nursing home after your hip fracture surgery. For somebody who has COPD, you might not be extubated if we give you general anesthesia. You might have a protracted ICU course. So the new way that is being taught to surgeons is now to do an informed consent with best case, worst case, most likely. And I'm going to show you that as a diagram. Let's see, which one should I point at? The little, okay, I'm giving up on the pointer. The little boxes come from the case study in this JAMA article. But basically, you try to draw a diagram for a patient, and there might be multiple options. But as you look at the screen on your left, as you talk to the patient, you make a star. Best case is that you have a fairly long surgery, potentially a short ICU stay, about a week in the hospital, and best case, you go out to rehab and then home. Worst case is you have a surgery with complications because of your Parkinson's, complications because of your COPD, but we have difficulty getting you off the ventilator, and perhaps you even die in the ICU. So you would symbolize that with a black box. That's worst case. But the most likely case for a patient like this, if he chooses to go forward, would be a clean surgery, easy surgery. Maybe we can even ask if anesthesia doesn't have to use general. Maybe they can use some other anesthetic methods. Short time in the ICU, maybe getting out to nursing home, and maybe or maybe not getting back home after. Your other option, sir, is instead of doing the hip surgery, we could just do supportive care. And then you do best case, worst case, most likely case on the supportive care line. So you're talking not just about the surgery, you're talking about all of that cascade of events that happens to older adults. Because as we know, they often make it through the procedures, but it's the after effect on the body or the comorbidities after which are challenging. And this is again being taught as a communication framework for surgery working with older adults. But I think it is also something that could be taught to other physicians who are a little uncomfortable maybe with a full shared decision-making model. So Joe tells you his main goals are preserving his cognition, preserving his independence. He would not want a long-term vent, and he wouldn't want institutionalization. He likes walking. He just takes long walks every day. And he would trade some pain management to preserve the other things. And he says, you know what, let me roll the dice. What do I got to lose? I'm already 80, I've had a great life. But you know what, if I end up in the ICU, no trach, no peg, let me go. But one of the other things with shared decision-making is how much risk each patient will take. Other patients might not take this risk. But maybe Joe's been a businessman. He's always kind of like, played the horses and done a little risky things. He decides to pursue surgery. So some of the challenges and sort of the delights in doing geriatrics are that older adults are really a heterogeneous population, both in the severity of their diseases, their goals of care, their functional status, their prognosis, and their risk of adverse events, and then their priorities for treatment outcomes. More than 50% have multimorbidity, which is defined as more than 3 diseases. And most treatment guidelines only address a single illness. So shared decision-making allows the patient and their provider to reach mutually agreeable outcomes. So.
Take 5 minutes for questions.
Sure.
And then we'll have a town hall afterwards.
Okay.
So, thank you, Dr. Doberman. That was fantastic. Are there any questions? We actually have 5 minutes with her discussion. Any questions or comments about what was presented? I do. Oh, okay.
So I like what you said about collaborating with the patient.
Can you use the microphone?
I like what you said in terms of collaborating with the patient and defining their goals. I've found in practice that it actually takes less time to ask open-ended questions and get to the problem faster.
Absolutely.
That's the real problem. And what I've been taught is do one thing during that visit to make a difference to that patient today and in the future. It's hard to do that when they have so many things. So by asking those open-ended questions, you can quickly find who wants to work on that day. And that actually, in the long run, shortens your visit, makes it more valuable to them. They don't mind waiting to see you necessarily. That's the case because they know that's how you work.
So, so the comment is in this person's practice, he has found that if he asks open-ended questions and very quickly drills down to what the patient's agenda is, it actually makes the visit go faster. It's more rewarding for the patient. I think I got it. and then it makes the visit actually shorter because you're on the agenda that the patient wants, and ultimately it's more satisfying for both people. That's actually what the literature does show. It actually does show that if you can find what the patient's main concern is, and actually physicians who start with open-ended questions, the interview portion of the exam is actually ultimately shorter. And then you can have patients come back, but yeah.
So Dr. Doberman, I'm going to be the devil's advocate here. So we talked about a communication framework shift. I've known many surgeons throughout my career as a pharmacist, especially when we talk about choices and decisions. And how is the culture changing? I think because what you're talking about is talking not just about an intervention, because there tends to be more focus on interventions, but now talking about non-intervention. So how are you finding the medical community changing with that framework?
So it's interesting. So the study that so asking the question about how has this new framework for educating surgeons around best case, worst case, most likely scenario, how is it being rolled out or implemented? This is actually a new research study just in kind of the last 12 to 18 months. And if you just read the JAMA article, or there's the authors have one prior, they actually have quotes from the surgeons prior to using it and then after about sort of their surprise at how well it was received by the patients and the families. And it's also interesting for me, having worked in multiple hospital systems, because each hospital has its own culture. And I actually think that hospitals that have very strong palliative services, surgeons are more comfortable with a comfort care approach, because they know that they can turn that patient over to another set of providers who.
Hi. Oh, thank you.
Systems where when you're talking about comfort care, but you can't describe what that is, it's more challenging.
For those of you online, I want to make sure that you feel like you're engaged. Do you have any questions for Dr. Doberman? You can unmute yourself and just ask through your microphone. Okay. Yes, Dr. Magaziner.
I have a question about what you look at in the United States. Where do you think we are with regard to reimbursement systems, with regard to changing surgeon behavior in the hospital? I know that in some systems, surgeons are paid, probably very few systems, are paid a salary. And in that system, maybe you could work something like this. But in a system where they're paid by performing a procedure, how do you engage surgeons in this process? Question one. Question two is there another way of getting at the same thing without requiring it to come from the surgeon, or having the surgeon as part of a team that would actually accomplish the same goals, but without the surgeon having to question his or her motivations, the conflict in terms of what they do?
Right. So the question is, how does reimbursement for surgeons in a fee-for-service environment impact whether or not they'll do a full informed consent and a shared decision-making process, such as I showed? And could others in the system do it? You could move it upstream. You could have ER physicians kind of do a shared decision-making and triage to a palliative team, for example. One of the challenges sort of is Maryland has a very different payment structure than most other parts of the country. Medicare is moving toward bundled payments. And so where there's payment for an episode of care. So the entire ER, hip fracture, and post-acute environment care are all going to be paid as one unit of care, with all people being vested in that outcome. So currently when surgeons do an operative procedure, any mortality within the first 30 days is thought to be related to that surgery. So it marks on their outcome, even if the patient dies of a pneumonia, an aspiration pneumonia. So I think everything in the system, now that we're moving to value-based payment and values, I think everything's a jumble, and Maryland is a one-off. But I do think actually the motivation for people to move away from a paternalistic model of communication to a shared decision-making model, whether you do best case, worst case, whether you use open-ended questions. The Vital Talk is another method on the internet. No matter what way you do, I really think every provider who works with the patient should engage in shared decision-making. That's really the take-home, no matter what you do. And that's how healthcare is flipping.
Thank you. We'll have a moderated panel at the end, but thank you, Dr. Doberman, for those questions. Thank you. All right. Next, we have Dr. Resnick, and Dr. Resnick is going to go into pain care plans and monitoring risks and the role of the interprofessional team. So let me grab up her slides here. All right. Go back to the... Come on up, Dr. Resnick. I'll get the slides going here. And welcome. Again, for those of you who don't know Dr. Resnick is a professor and endowed chair over at the School of Nursing here on the campus. Let me just share the screen with our folks online. I know it's complicated, right? Oh, I'm trying. There we go. Share screen, open that up. And hopefully the recording. So as noted, if we have time, we'll answer some questions at the end. After this session, we'll have a quick break, a bio break, I tend to call them. But if you have any questions, just make sure you use the microphone in front of you for recording purposes. As now, I'll turn it over to you. Thank you.
So I'm going to take us a little bit to probably, hopefully, a world that you're all familiar with. The long-term care world, the assisted living world, and a little bit about primary care, but I think we just heard mostly about kind of that primary care. I'm going to say the younger, older adult. But before I start, I just want to put, I think, the bigger elephant on the table. When we talk about pain, we all bring our own bias about pain. I don't know how many of you sitting in the room have ever had either really bad acute pain or live with chronic pain. And every single person has their own, you're going to forgive me, mishigas about pain, their own craziness, okay? I don't want to have any pain. Some of us, as I always say to my patients, you know, having pain means you're still alive. You're still feeling something. And what level of pain relief you expect. And that's the real elephant. And I think we, as healthcare providers, and I'm a geriatric nurse practitioner, I practice, and I got to laugh when I listen to this, because in nursing, it's like, it's always what the patient says, and it's like, seriously? Like, you had to learn that? Because it is something that we sort of, it's the core of nursing. But all of us bring our bias. And I think we have to think about that when you sit in front of a patient and make sure you remove in some ways your own bias. Like I know with me, like having some pain is an okay thing. I got to deal with it and I'm willing to deal with it, but maybe that patient doesn't want to. So I think it really is getting at as much as possible what that patient wants, what they might have wanted and how they might have dealt with pain in their earlier life. Was this someone who really liked to take drugs, or was it somebody who really didn't? Because that's a reflection of how quick I want the immediate, I want that pain gone. And we all know people like that. Some of us may have spouses that way, etc. We're not saying anything more about that. I have no relevant disclosures, and I think remembering again, actually the pain is just nature's way of keeping you humble. So I think we have a real exciting opportunity. I don't know how many of you work in the long-term care world, but there's real nice opportunity to include pain in care planning, which is now a major requirement in the long-term care environment. And you had better do it, you had better do it well, and you had better do it quickly. So there is a requirement for a current kind of a chronic care, long-term care, care plan to be developed. You have to do it initially, and you have to do it comprehensively, the whole team, and repeatedly. Now, you will notice it's probably really hard to see that. There's many, many things that need to go into that care plan. Pain is not clearly delineated there, but it could be incorporated into many of those areas. I think it's sort of interesting that it wasn't there explicitly, but it really isn't. We have medications and sort of many things that would come into pain, and it is part of the MDS, part of the assessment that we look at, but it's not actually required as a care plan component. I think we bring it in maybe through many ways, but again, as a team here, it is our responsibility to address it, because who has more pain than older adults in long-term care, in all honesty, between the multimorbidities and the sedentary behavior, and I'll talk a little bit more about that. So it's not in the comprehensive care plan, but it's an opportunity, and I hope those of you who are going to be or are consultant pharmacists will sit in that care plan and bring it up. Resident involvement is another thing that's new, I'll say, required, but it's a big deal now. The resident has the opportunity to be part of that care plan, to have a copy of that care plan. It can no more be something that's done in a closed room that the patient and or their licensed, authorized representative, whatever their proxy, doesn't know anything about. Now the patient has to be informed. They have to have a copy of that care plan. The baseline care plan has to be done within 48 hours of admission. Think about that. That's getting everybody in there to assess, and it's got to be interdisciplinary. So it doesn't have to be the perfect care plan. That can come later, but we do need to get something together in 48 hours that's interdisciplinary. It's a pretty hard task. It really is. I'm not even sure it's realistic. And I was involved with CMS when we developed this. And let me tell you something. There was a very, 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 very long debate over that 48 hours. Pro and con and whatever. And then there was some talk initially really about 24 hours because that patient is there and they need care. So again, opportunity here to think about. Those are the requirements, and you can look it all up, and I give you the codes for that. It's I think a 679-page document if you want to review all the guidelines. It's just fascinating. The intent, again, is to really promote continuity of care, communication among the staff, increase resident safety, safeguard against adverse events, particularly those that really occur quickly after admission, ensure the resident and their representative are informed of the initial plan of delivery of care and services, and that they receive a summary. Now, those of you who work in this industry, think about this. When do we know so many patients come in? 5 or 6 o'clock on Friday evening, right? Seriously, is this happening over the weekend in these settings? Very, very, very difficult. And we're going to have to see what happens. These are new regulations. So again, real opportunity to address pain in care planning. I'm going to move to another setting of care, assisted living. So in assisted living, pain management would be or could be incorporated into what we refer to as a service plan, which is a requirement in assisted living. Now, what are most service plans sort of focused on these days? I think a little bit about what the patient is paying for, whether they need help with bathing, dressing, med management, whatever. But there's a real opportunity here, again, to address pain in a population where pain may be even more challenging to address than it is in the long-term care setting because of the type of caregivers that are there. There's also state-by-state regulations around things like medication management, whether somebody can even give a drug to a resident or whether they take it, they have to be able to take it themselves or some sneaky way that we won't talk about here. Then we have pain management in primary care and in home settings. And I think we just heard It is so critical for the patient's goals and expectations to be considered. I think in some cases, we really have to address the fact that it's not realistic to think about having no pain. In some ways, none of us have no pain. So why is that, you know, with this pain as the fifth vital sign or whatever, what is the expectation? And I used to laugh. I recently went through quite significant treatment for cancer, and every time you go in for the visit, they start with what's your pain level, and the new one is also what's your fatigue level. And I would look at this person and go, like, seriously, you really going to deal with this? Like, you're not even looking me in the eye as you're asking this question. Can we not go there? And I never, not once would I answer that question. So I was the bad girl, but I just had to blow that data, because it's really, like, seriously, you're expecting me to have no pain, no fatigue. What world do you live in? It ain't mine. So I think it's being realistic with patients about that expectation and finding out, is that really your expectation? And what is their experience and thoughts regarding farm and non-farm interventions? Because I think that's a really helpful, it's certainly totally asking the open-ended, but also finding out what prior experiences have been and really what their bias is, what their thought. Like, do you think acupuncture is really out there, or is it something that's a go-to for you? You know, is yoga helpful for you, or is it not? Or as I tell all my patients, my way of managing pain, put my headphones on and go for a walk, and I can deal with anything. Pain assessment is another big challenge. It's almost as hard as managing the pain. Pain is very much a subjective symptom. Those who are cognitively intact can tell us and report it at some level. You know, it's very difficult for people to articulate pain. It's also really hard to remember pain. So you could have had horrible pain in the morning when you were getting dressed, but now when you're at the provider's office, you're sitting in a chair and you're not having any pain. It's hard to remember that morning pain. Thank God it's hard to remember, but that makes pain management all the more challenging. Approximately 30 to 50% of individuals with dementia experience pain, and that's often presented in symptoms that we see: aggression, agitation, withdrawal. You know, what is your behavior when you have pain? Do you want to curl up and have everybody leave you alone, or do you want to kill the person sitting next to you? I mean, everybody is very different, and it is presented differently. So we need tools that will allow us to evaluate pain with those who are able to share with us their pain versus those who can't. So one measure that I have found useful is the verbal descriptor scale. And I find it a useful way to evaluate subjective pain, better than that 1 to 10. The 1 to 10 sends me to the moon. I think it's very, very difficult. And I know constantly throughout my hospitalization, every single second, it was like, what's your pain on it? Every time they give you medication, you get asked, what's the 1 to 10? And I would be really nasty. I don't know, it's about 25 right now. What are you going to do about it? It is well beyond 10, so leave me alone. It's hard to describe and hard to put in that 1 to 10. The verbal descriptor scale gives you an opportunity for the patient to say, I have no pain, I have mild pain, moderate pain, severe pain, or extreme pain. And then to point to or show where the area of pain is. And this, again, has been used with older adults, including those with some mild to moderate dementia, which is why I've found it useful, because they do better with describing the pain versus giving it a number. Here's a sort of cute cartoon about the number. What is your pain level on a scale of 1 to 10? Unacceptable answers: 12, 100, a million, -3. Absolute refusal to give a number, that would be me. Number provided for every activity you can think of, the person that comes in with the notebook. An irrational number, pi. And the square root of -1. which does leave the provider sort of not sure what to do. So there are some challenging patients. Another pain assessment that I like to use for people with advanced dementia, really those that cannot articulate pain, they can't even tell us they're in pain. We have to see it. And this is the pain AD, the pain for Alzheimer's disease. This includes 5 behaviors that are commonly noted among individuals with pain. The observation should be done during periods of activity. And I use this a lot in research, and we always have the evaluators evaluate people while they're doing something. Because as I said, we can all get us, hopefully, into a position or a situation where you're not, or you're having the least pain that you can possibly have by sitting still or whatever it is. So the scores in this range from 0 to 2 for each specific pain behavior. The verbal descriptive scale, I just wanted to show you what it is. First you ask if the person's experienced pain, and then how that pain is, what the level is. And in the pain AD scale, we observe. So we look at breathing, we look at negative vocalization, facial expressions, body language, and consolability of the person, and just rate it. It's not perfect, but it's a way to at least think about, is this person experiencing pain? The other, as a provider, the other really big way I evaluate pain is to get the person to move. Even when I know it's going to cause pain. And I teach advanced practice nurses. And one of the hardest things I have teaching nurses is you have to get the person to have pain so that we can know where it is and best deal with it. And that's a really hard thing for providers to do, but it's critically important in this population. Sometimes I don't know a person's got pain until I get them up and move them. And I always have clinicians try and do that so that we can deal with the pain and help the person ultimately get through the bigger part of the day. Here's another 1 to 10. Really, sometimes the pain gets to the point where really it is too serious for a number. So care planning pain. Pain is probably one of the most difficult symptoms, I think, to deal with because there is no perfect solution. I love the slide that goes through the pain, the pharmacological interventions. They are not perfect. Everyone comes with a price. And I think really combining behavioral and pharmacological management, and it is the appropriate use of drugs, not the yes, no, but some of the non-pharmacological options we don't take enough time to deal with and think about and use and implement. Our positioning, physical activity, ice, heat, and local treatments. Some of my favorite treatments are icy hot, right over the counter. Ice, heat, and local treatments, music and distraction. And increasingly, we're seeing everybody in long-term care now has headphones, like it is just the style. And now we're getting to the point, excuse me, but they really, like, when they're eating, they need to take the headphones off. Or if you've ever worn headphones for a long time, it gets uncomfortable after a while. It's, we kind of jump over the edge. And part of the issue I think we all need to think about with opioid use is we don't want to take them away altogether, which is my biggest concern in long-term care. And then considering, I think the local treatments are very helpful. At least you feel sometimes like you're doing something, and even if they're short-term treatment. And then any other behavioral interventions, ask people what they've done in the past. One of the best studies I ever did was a qualitative study with older adults in pain to find out how they managed it, and it was just fascinating. People go through amazing ordeals of, well, when I get dressed, I put my arm in this position or I hold it in this position for 26 minutes and the pain goes away or whatever. But we have a lot we can learn that way. Not sure if you can see this, but the one on the top is, okay, your doc said, if you like, you can swap your branded pills for these generic suppositories. I really like that slide though, because I think it's a reminder that some of the pain medication comes in suppository formats. And if you have sort of GI symptoms to some of the narcotics or even non-steroidals, a suppository may help you get around that. So while they don't have to be that big, it is an option. And I had one provider who sort of looked at me and said, you would like choose to take a suppository? And it's like, honey, if you're having nausea and vomiting, you would choose to have a suppository too. So I think keeping that open as an option. And the bottom slide is just cute about the whole issue of before, oh God, I feel like crap. Well, that's what happens when you don't exercise. Oh God, I feel like crap. Well, that's what happens when you do exercise. And there are pluses and minuses. But I think, again, helping with musculoskeletal pain, a lot of times physical activity can be a big benefit. So care plans, forms for the long-term care setting. I believe I sent that in as a handout, but there are some nice formats if anybody wants those. Once developed, though, I think what we try and do is develop to something we call a snapshot, because what happens with care plans? Nothing. That's it, guys. You're absolutely correct. Nothing. Silence, dead. They're never used. They are, in the old days, we would say we would sort of dust them off. Now they're in the computer somewhere, buried deep and not used. So we take them out. We develop them into what I call a snapshot. And then place them somewhere where the people providing the care can see them and use them. What a novel idea, right? This is just an example, and I won't go into it in great detail, but it's an example of a snapshot that you could put up in a resident's room and actually look at and use. And this is one on pain, and it talks about, she uses heat. You know, heat is helpful to this person, but it just gives you kind of the tricks of the trade, person-centered approach to what would work with that individual. Of course, you first have to go through the details and develop that, right? Which requires all the things I think we just heard about, of really getting at that patient-centered approach with the resident and or their hopefully family member or whoever their proxy is, or the nursing staff that often become their proxies, particularly with regard to pain. In the assisted living setting, I think there's just a couple of tidbits I wanted to bring up, because this setting is very different from long-term care, because you don't have nursing staff there 24 hours a day that can make decisions around what are referred to as PRN, pain medication. Nursing assistants can't do that. So if a drug is ordered, it has to be ordered continuously. You can't do a PRN opioid, not an option. And so I think it's really thinking about that and building in, you know, how are we going to manage this? And this is where, truthfully, there is a lot of push to move from that, you know, the patient might need it occasionally to, like, let's just give it continuously. The next big issue is getting people to do the things we need to do from a care plan perspective to treat the pain in the patient. And now I'm really talking about motivating staff and using what I refer to as a self-efficacy approach. Getting them to just try it. Like, trust me, if you use heat, it will really help this patient. I know the patient, I've seen it, I know that this works for her. Getting them to do it, just getting them to try it. Role modeling. I go into the long-term care setting, and when people are sitting there all the time and getting a little agitated because their back is killing them or whatever, I get them up and move them and show the staff that that can really be effective. And yes, they may have a little pain when they first stand up, but as you move, and sometimes with arthritis, it takes really a long walk before the pain is relieved, but at least we can get it started. And then eliminating the unpleasant sensations for the caregivers. So yes, the easiest thing, you know why nurses love to give pills for pain? It's really quick and easy, and I am done with it. I've done something. Some of the behavioral approaches are harder and take longer. And so helping people think through that, believe it's going to help, because everybody really does want to relieve the pain. And then there's the ongoing evaluation and reevaluation that needs to be done. And I think what we're going to see more and more in long-term care, like we've seen around falls, is pain committees. And we'll do pain rounds and pain reevaluation as this, I believe it's going to be the next kind of falls focus, you know, with the opioid crisis. And again, an exciting opportunity to really address pain more comprehensively in this setting. I think we can think about monthly pain rounds, including pharmacy within that, looking at drugs more carefully. I think we're going to see the same thing around opioids that we're seeing now around the psychotropics. It's definitely the next thing. We'll be getting rid of the low-hanging fruit and looking more, hopefully, at appropriate drug management. And in primary care, I think it's just critical to evaluate pain at every patient encounter, but not asking the 1 to 10 question, but really asking qualitatively more about pain, incorporating behavioral and pharmacological approaches. Again, that patient who likes acupuncture, I get called all the time about, you know, who's a good acupuncturist, and I just make it up. I mean, you know, I haven't been to every in the world, but I give good referrals. But patients will, if we're open to it, come to you and ask. I think believing in the benefit of whatever approach the patient and you have worked on, and what, you know, be careful, like, as I said at the beginning, of your own bias. Like, seriously, you really think that icy hot is going to work? Versus me, I'm like, oh, this stuff is great. Just you can use it as much as you want. It'll feel really great. It'll really help. I can't promise it'll work all day. You may have to use it repeatedly. And then one of the most important things, and you'll only remember 3 things from any presentation, if you can remember one thing, and that is to never tell anybody nothing more can be done about your pain. I think it's the worst thing we can say to patients, and providers sometimes get frustrated with pain because it feels like, oh my God, I've tried everything. For pharmacists, like, there is no more drugs in my back pocket. Everybody wants the perfect drug solution, will relieve the pain, but make me able to do everything I ever wanted to do. And there is nothing that works that way. And then I think being really innovative, taking a person-centered perspective, what the individual enjoys that may serve as a distraction. For me, as I said, it's going for a walk. For some people, it's music, whatever works. And I think also the whole area of placebos. In the School of Nursing, I have a colleague whose entire research program is around placebos. We know they work, and we all have our own placebos. Everybody comes up with their own mishigas about what pill. You know, I don't care if the M&M, you know, chocolate helps many people with pain. Whatever works. Thank you. I think we're right.
Okay, it's technically break time. So do you have any burning questions, though, for Dr. Resnick before we go into break? We're going to have a moderated town hall at the end, so please write your questions down. But please take the next 14 minutes. Network, use the bathrooms, which are immediately out to your right. Fill out your evaluation forms and hand them to some of our students that will be circulating around. And those of you online, we'll just have you on the hold, and we'll start back up promptly at 10:30. So thank you. And let's introduce our third faculty presenter. So many of us who work in palliative care know Dr. Lynn Mcpherson. Anybody in the field of pharmacy knows Dr. Lynn Mcpherson. So,
but I'm still 29. That's the official story.
That's the most important thing to note, right? So many titles. She's an amazing presenter and educator. So excited to launch our first seminar series with the Palliative Care Collaborative. So again, thank you all, and turn it over to Lynn.
Okay, thank you. So good morning again. So Dr. Resnick gave my whole talk, so this is pretty awesome. So are there any questions? All right, I'm going to talk a little bit more. I'm going to do a little bit of a deeper dive into the drugs. I mean, hello, I am the drug girl, so I think I kind of have to do that. To talk about what are the changes with aging that affects the way we select and use analgesics. But I agree with Dr. Resnick. Even though I am the drug girl, drugs are not completely the answer. So I do think non-drug interventions are so darn important. My one plea would be we need more research on the non-drug interventions. And the second thing we really need is insurance companies to pay for it. There is better data about massage for low back pain than drugs. So why won't they pay for massage? And I think Dr. Resnick mentioned acupuncture, getting referrals for acupuncturists. I took care of a man who had a concrete ceiling fall on him when he was doing construction and obliterated his hip. So he's got all this hardware in his hip, and he's on massive opioids. And then finally, and he's a 6'8" man, who's very stalwart, very no foo-foo about him. I sent him to an acupuncturist with him looking at me like I just suggested he drink the blood of a chicken. But his pain went from an average of 8 down to 5. But then the nurse case manager with the insurance company said from workers' comp, that was not enough of a reduction in the pain for them to pay for acupuncture. And he couldn't afford to pay for it out of pocket. So then his pain went back up to an 8, and then they were nailing me to the wall for using so many opioids, which, of course, being a shy, retiring little cupcake, I slammed her back and said, then pay for the bloody acupuncture. But enough about me. All right, so I think it's no surprise. I mean, anybody who's lived to be 65 years old, of course we all have pain. I agree with Dr. Resnick. If you're not having pain, you're probably dead. I actually saw a T-shirt that said, any day that I wake up and nothing hurts, I have to wonder, am I dead? Because that is so true. That is absolutely true. The other saying I roll with is, any day I wake up on the right side of the dirt is a good day. So that works for me too. But we do see that a lot of people have pain. 75% over 65 have 2 or more chronic conditions that absolutely lead to pain. And under treating pain, particularly people who are nonverbal. Oh my gosh, it's horrible. So if you look at this slide, can you think of examples of painful conditions in every one of these organ systems that would cause pain? My goodness, I couldn't make the font large enough for you to read it because there are so many reasons why people have pain. My primary practice is in hospice and palliative care, and I always find it a kick in the pants when a hospice patient says, I can't believe I had to be freaking dying before somebody paid attention to the pain in my feet from my diabetes. That is shameful, isn't it? It's absolutely shameful. So elements of a comprehensive geriatric pain assessment. These next few slides come from a very nice document from the United Kingdom, which I think I have the reference in here. I'm a big believer. I do like a multidimensional pain assessment instrument. I know Dr. Resnick expressed very articulately her dislike of the pain severity rating scale, and I'm with her on that. But I do think it's more than just the number. And I'm constantly surprised by the number. I'll ask a patient, for 27 years I had a primary care practice, and I would say, how's your pain? Oh, girl, you are so awesome. My pain's a 7. And I'm like, a 7? I would be under the bed curled up in a ball if my pain was a 7. And here you're skipping rope telling me how awesome I am? So do not tell me. And sometimes my students will say, it's a number, so it's objective. I was like, yeah, pull my good leg. Let's draw a blood level, run it down the lab and say, you lie like a rug, girl. It's not a 7, it's a 4. You're pulling my good leg here. So I do like a multidimensional assessment, both the sensory. Do you think there's an emotional component to pain? If you're a woman who has pain and your mother died of breast cancer, Mets to the bone, what are you thinking? You're thinking, don't buy green bananas. Functional impact. I mean, asking that pain severity number is a surrogate marker for what we're really looking for. Just like measuring my blood pressure is a surrogate marker for my risk of having a heart attack or a stroke. So really, we want to know about the functional impact. And this is where it all has come from, with the opioids not really being the drugs of choice for so much of chronic non-cancer pain, is that they're not improving functionality. So if you can't sleep better or go back to work or play with your grandkids or take a walk like you used to and take Fluffy for a drag, then we're not meeting the mark. Sleep, huge impact of pain on sleep. And coping styles, what do you do to cope with pain? So important. Attitudes and beliefs. And I personally spend a lot of time exploring attitudes and beliefs about pain medications. What do you think happens in my clinic when I say, what do you think about methadone? What do you think all my inner city little old ladies say? Mm-mm, baby. Mm-mm, mm-mm. My grandson's on that stuff, and no way, baby, are we going there. Okay. All right, so you did see some of these from Dr. Resnick. I agree, the numeric rating scale's a little tough. And you know what really impresses me about that is how many healthcare practitioners screw it up. They say 0 is no pain, and what do you think a lot of people say 10 is? The worst you've ever had. So I'm looking at Dr. Whitaker, she's 12 years old. I know she had a baby, so not counting Junior. What's the worst pain you've ever had in your life, 0 to 10? A split end. She had a split end, God bless her heart, so maybe it was a 3, right? So it's the worst you can imagine. It's having triplets while you have 2 broken legs and end-stage pneumonia. That's what a 10 is, okay? Now, some people, 0 to 10 is too many choices. So particularly older adults, they do better with 0 to 5. But the drug companies, God bless them, Lidoderm got approved on a 0 to 100 scale. And they were super duper excited saying, oh, our drug reduced the pain 10 points. Do I have to take off my socks to figure out that's a 1-point reduction on a 10-point scale? Is this really clinically important pain relief? So what is clinically important pain relief on a 0 to 10 scale? Dr. Feinberg, what do you think about that?
Well, I would say like 1 or 2 that I can't.
So she gave the best answer. She's such a cheater here. She went right for the gold. Functional improvement. But seriously, when you're looking at a 0 to 10, what do you think? He's got to vote for 2. Anybody else want to render? What the patient tells you, true. But there actually is an answer to this. Consensus opinion, a 30 to 50% reduction on the pain scale is considered clinically important pain relief. So if the patient says my pain went from 90 to 80 on a 0 to 100 scale, that is, I mean, okay, we're going in the right direction. That's really not clinically important pain relief if you're looking at that. So again, all kinds of way to do that. Most older adults do prefer the words, which, you know, is probably just as good or better, as you heard, than the numeric rating scale. And this is the picture of the pain end scale. And actually, I got a small grant from the campus for interprofessional education where I hired a standardized patient, an actor, who actually does Western movies when he's not being a standardized patient. And I went to the nursing school, and they videotaped him doing all the things that go into this tool and the checklist for nonverbal pain indicators. So I had him do breathing all the way from normal all the way up to, I'm so evil, I had him imitate Shane Stoking. And then I had him like stop breathing and be apneic for a little while. So we didn't take too long on that because he got a little blue. But we went through all of this, and then we filmed 3 vignettes where we are going to have students use this tool to evaluate the pain. So we're pretty darn excited about that. And again, non-drug interventions, so much of chronic non-cancer pain is lifestyle modification. So I took care of, until I left that clinic, an 80-year-old woman, inner city African-American woman with fibromyalgia. And I said, you know, really the answer to fibromyalgia is to lose weight and treating your depression and a good night's rest. And really the answer is aquatic therapy. It's not OxyContin. So she would look at me and say, Cupcake, you want me to put on my bikini in January, walk 2 blocks to the bus, take 2 buses to get to the public pool. I have to pay to belong to the pool, and then reverse all that, and I'm 80 years old. Can't you just freaking give me my OxyContin 2212? You know, it's really hard to argue with that. You know what I mean? I think at a certain point we have to consider, is this palliative care? I mean, we think of palliative care and dying. Not dying, but still, it can be very difficult. I understand that. So when we look at pharmacokinetics, I learned this from Dr. Feinberg when I was a student, and Dr. Brandt, of course, has reinforced it. Absorption, distribution, metabolism, and excretion. What happens here? Well, absorption is how we absorb drugs. There's not a huge impact from aging on absorption of drugs, particularly the drugs I deal with. Distribution, there's a little bit of an impact. So for example, we see an increased free fraction of albumin-bound drugs. Nobody really uses phenytoin for pain anymore. But my favorite drug in the universe, which is, where are the students? What's my favorite drug? Methadone, absolutely, is bound to albumin and a little bit alpha-1 glycoprotein. And we do see an increase in the free fraction. So that could be clinically significant. Altered volume of distribution, some drugs like morphine, very, very water soluble, all the way down to methadone and fentanyl, which are very fat soluble. As we age, we have more fat and less lean tissue. So that can affect the volume of distribution. This is a big one, metabolism. So when we look at a drug like methadone, if someone has liver impairment or from aging and decline in liver function, that's going to delay how the drug gets detoxified. Probably the biggest one, of course, is excretion. So when I look at drugs like morphine and hydromorphone, which are metabolized extensively, and I have a slide on this later, they're both metabolized to a 3-glucuronide metabolite, which can accumulate with repeated dosing. And if you have poor kidney function, the serum level is going to go up with those, and it's a known neurotoxin. It actually, what does it do? It causes delirium, it causes myoclonus, and here's the real kick that has. It makes the pain worse. So it's called opioid-induced hyperalgesia, where patients will tell you, you know, you increase the dose of my drug, it got a little bit better, but then it got like way worse. And my pain went from being here to being here. And now if you just touch me, I want to jump off the bed. That's allodynia, pain from a non-painful stimulus. All right, I'm going to put you to work. I'm going to give you 30 seconds to talk to the person next to you, and I want you to put these in order from safest to the riskiest. Go. Not always. Generally speaking. Co-analgesics are things like gabapentin or amitriptyline. It's like gabapentin, things like that. All right, what do you got for me? Who wants to tell me what they think is the safest from these four? Nobody wants to opine here? Which one's the safest? Back row. Which one? Oh. Don't make me smack you all. Generally speaking, population-based data, just gut syndrome here, gestalt. Which one do you think is the safest? Who thinks it's acetaminophen? Any other votes? Opioids are the safest? Wow, I want you to treat my pain. Ooh, baby. Dr. Resnick, what do you think? Acetaminophen, Dr. Brandt? Ooh, she's worried about the liver. How about that? Yeah, I agree. It depends on the patient. If I'm an alcoholic, you certainly would not put acetaminophen as the first line drug. Of course, you're pretty much SOL with all these drugs if you're an alcoholic, right? Shucks, out of luck. Dr. Simone Wastilla? Yeah, no crazy risk factors here. Dr. Doberman? Interesting. Did anybody pick the co-analgesics as the safest? She said she thought she might put the opioids as the safest. But no, I said I did want them to take care of me if they picked the opioids. I want to live in their village. You picked the co-analgesics? Why? Okay. Okay. Do you all agree with that?
It's been a minute.
Yes, she's saying she thought the co-analgesics because they probably had the least toxicity. I agree. It depends on the co-analgesic. It depends on whether you're using a steroid or a gabapentin. And, you know, doctors like to start little old ladies at gabapentin 303 times a day, which could drop a moose. And then they wonder why they complain that they feel like a drunk monkey because you dosed it wrong. What's wrong with you? What do you think is the most toxic? Oh, Dr. Whitaker's going big with the NSAIDs. What do the rest of you think? Why do you think the nonsteroidals? Yeah. 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 Who voted for the nonsteroidals as the most toxic? Who voted for the opioids as the most toxic? And the rest of you, what, aren't going to vote? I mean, surely you didn't throw Tylenol under the bus. Come on. What do you think? It could be the co-analgesics. I agree. It's not really a fair question, but if somebody asked me, gun to my head, I would say acetaminophen's the safest. I think probably next to cholanalgesics if you dose them appropriately, then the opioids, then the nonsteroidals. I think the nonsteroidals are a clear sign Satan is alive and well today. I think they are one red hot mess. So acetaminophen is still first line per the guidelines for osteoarthritis, for example, if you follow the dosing. I always say, what does APAP stand for? Who can tell me what APAP stands for? What is it? Look at you. Normally I say, I have $50 in my pocket if you can tell me it's yours. Thank God I didn't say that today. You are old school. The only time I ever had anybody else give an opinion was Frank Palumbo said, I don't know, but I'm thinking anti-pain, antipyretic. I'm like, that's wrong, but I like it. So it is pain, it's analgesic, and it's antipyretic. What's the maximum daily dose? I got to vote for 4. I got to vote for 3. Can we split the difference? 3,500? What am I hearing here? It is 4 grams a day, but good luck finding that as a reference from the FDA webpage. Where did this 3 grams come from? What the heck? Would you like to know the Mcpherson philosophy of how this came to be? Because the FDA formed an advisory group 10 years ago and said, what are we going to do with acetaminophen with this increased risk of toxicity and all these deaths in the mid-90s, the latter part of the 90s? And they formed this advisory group, and their recommendation was keep the 325 OTC and make the 500 RX. And the McNeil people were like, the cash cow might be dying, OMG. So let's voluntarily lower the limit to 3 grams a day, because all you sweet young things in here, right? And you know I've used this line before. When you have menstrual cramps and you go to take over-the-counter ibuprofen, do you really follow 1,200 milligrams a day? No, you take 4 of those puppies, don't you? Because you know you really could take 3,200 a day. So I think the manufacturer voluntarily lowered it because nobody in their right mind goes to Rite Aid and buys the 325 milligram tablet. But that's my philosophy, because everybody really knows you can do 4 grams a day. You do have to be careful with liver disease. Not so much liver cancer, although that makes me a little nervous. But cirrhosis, certainly. It's a red hot mess. And alcoholism. Non-steroidals, very commonly used. Still very big, Maddie, would you say big sellers, big movers, fast movers? Non-steroidals? Yeah, absolutely. We have to worry about heart disease. So when does the risk start when you start a non-steroidal for a heart attack? When do you start to really see that risk start to accumulate? What do you think? Who would like to give me a guess? Like statistically significantly increased. Dr. Simone Wascella, you got anything for me? 2 to 4 weeks, she's saying. And she gave me that look like, I got nothing and I'm making this up. Dr. Mansar, what do you think? But even 1 at a time, the risk starts days 1 to 14 is the highest risk of having a heart attack. 1 dose, 1 freaking dose. Oh my gosh, that's terrible. And only 40% have cytoprotective therapy. But then you get into the whole thing of let's all jump on our PPI soapbox. Should everybody and their mother be on a proton pump inhibitor? No, that's not a good look either. And then there was the big precision trial that just came out about a year ago comparing ibuprofen, naproxen, and celecoxib, looking at cardiovascular outcomes. But here's the kicker. It was funded by industry, the nice people who bring you celecoxib. You were only allowed to go 200 milligrams a day on celecoxib, whereas the ibuprofen and the naproxen could be increased ad nauseum. And half the people there were on aspirin. And we do know that that has an interference as well. They showed that celecoxib, the risk of cardiovascular bad outcomes, was a smidge less and statistically significantly less. But it was very highly criticized. And I think if you had pushed that dose of the celecoxib, where a lot of people take 400 milligrams a day, it would have probably been not as good of an outcome for them. So I'm not sure what to make of those results. Lots of drug interactions. And adjuvants. Antidepressants, no, the SSRIs really do not help nerve pain. They really do not help. The TCAs, I like the TCAs, but you have to worry about cardiac conduction abnormalities. I don't like Elavil because it's the most sedating, the most orthostasis, and the most anticholinergic effects. But I do like nortriptyline and zipramine. I start really low on older folks, 10 milligrams at bedtime. Then in a week, I say, go ahead and take 2 of those tablets, so 20 milligrams. Give them another couple weeks. Maybe we'll kick it up then to 50 as our next step. Rarely do I go beyond 50. It works quite well. I like the gabapentinoids, but really 40% of people do feel like they were dragged through a bush backwards. If the formulary allows, I like pregabalin better than gabapentin because you can get to your dose much more quickly, but still, same side effects. And the opioids, are they effective for chronic non-cancer pain? You know, I think this is not just an older adult question. This is an everybody question. The American Academy of Neurology came out and said, please do not use opioids for low back pain, tension headaches, and fibromyalgia, because it is, you might as well give them Skittles, because it doesn't, at least the Skittles are formulary and they're a lot more fun, but it still doesn't help your pain. Same as an acetaminophen and a non-steroidal will never, ever, ever treat neuropathic pain. People are not targeting drug therapy. What if you really need an opioid in an old person? Is it safe to use? I mean, no drug's a free ride, but I'm actually safer, more comfortable with that than a non-steroidal. I was telling a couple people here today, well, you all know my favorite drug, but methadone milligram Q12, that could be freaking magical. In hospice, we have a lot of people 90 years old in a nursing home who just can't settle. I mean, there's something about, I mean, I have had arguments with physicians who say contractures don't hurt. So let's do a little exercise. Are you ready? I want you to make 2 fists. Come on, do it with me. Do it with me. Pull them in tight. Now squeeze it as hard as you can. Now you hold that 3 days and let me know how that's working for you, okay? You tell me you don't want methadone 1Q12. You know, no offense to nursing home people, but what does PRN stand for? I'd like to think it means pain relief now, but sadly it means patient receives nothing. So we have to be so careful. Here's the laundry list. Any favorites on the list? Anything you really want to take home to mom, or maybe not so much? Oh, you wanted Methadone second line? Yeah, it's an awesome drug. We'll all have a seizure. Levorphanol is an awesome drug, but it's a branded product, and it's about $2,000 a month now. Yeah, so no, you're not getting levorphanol for dessert. Any other favorites or ones you want to get rid of on the list? Who's up for a little codeine? The FDA has said, no, 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 no. Codeine's a naughty kitten. Codeine is the prodrug of what? Morphine, and not too predictably at that, very erratically. And of course, we always talk about drug-related variables and patient-related variables. Very important when we're making these decisions. This was a consensus document looking at if you're going to use an opioid in an older person, what's the short list? And these are they: morphine, oxycodone, hydromorphone, my girl methadone, bup, and fentanyl. I don't think we use buprenorphine to its best advantage in the United States for pain yet. I'm not a big fan of Butrans or Belbuca. Why not? Because they're expensive, and the Butrans is a very, very weak opioid, the way they have formulated it. Morphine, it's glucuronidated, and so again, it's the M3 glucuronide that can cause these paradoxical effects. Buprenorphine is a very clean opioid, actually. It's a very clean opioid. Fentanyl, I do like fentanyl, but it's very fat soluble, so if we're losing fat, you're going to have a higher free fraction. A lot of drug interactions with fentanyl, although people don't think of it, but it is a pretty clean drug from a renal perspective because it's extensively metabolized, but to inactive metabolites. And my girl methadone, same thing, metabolized extensively by 2D6, 2B6, which are both subject to genetic variability, 2C8, 2C9, 2C19, and 3A4 are workhorse enzyme. A bazillion drug interactions with methadone. I think we could teach all of pharmacy school just talking about methadone. That's all we need. We don't need any antibiotics or any of that stuff. Forget it. Oxycodone is okay. Active metabolites there. Hydromorphone, again, that hydromorphone 3 glucuronide metabolite. And of course, we all know the side effects. So I still hear people say, do you think it's going to cause constipation? Seriously? Really? You're not sure about that? You're fuzzy about that? It's going to cause constipation. Here's a little tip for you. Forget DocuSate. All it does is make things way worse. Just go with Senna or Miralax and have a good day. Done. Nausea, vomiting, sedation, confusion. They generally clear, but they may not. Uncommon, but certainly respiratory depression. You actually get some tolerance to the respiratory depressant effects after about a week. But, you know, if you will always hear the start low and go slow, never is that more important than with opioid therapy. Oh, my goodness, for everybody. And itching. Itching is not an allergic reaction. It's a pseudoallergy. It's due to histamine release. So don't give them an antihistamine. So you got grandma who's 140 years old and you give her Benadryl, and now she's a raving lunatic and she can't pee because of the anticholinergic effects. Rotate to a new opioid. Call me. We'll do methadone. All right. Key points. Link potential treatment benefits with important patient goals. So that is the big payoff. So, you know, when I start a patient on an opioid, I begin with the end in mind. What would you like to be able to do that you can't do now because of the pain? You want to be able to take Rover for a walk and stay in bed for 6 hours and not wake up in pain. Great. I'm on it. But we're going to look at how you do on these different analgesic regimens to see if we meet those goals. And if you're not meeting those goals, then we're barking up the wrong tree. So stick with me. I'll stick with you. We'll keep swinging because, you know, I don't know exactly what's the magic cocktail for you, but you have to recognize, I mean, if I say to you, I'm really sorry, but this lisinopril is just not cutting it for your blood pressure, so I think we're going to switch you to diltiazem. I mean, is she going to cry about it and get upset and say, oh my God, oh my God? No, but people do that with the opiate. So we have to be very careful there. Use medication combinations in which each analgesic works differently to enhance the effectiveness. So I've got a wonderful slide, which is not here, looking at chronic pain. What drives chronic pain? Peripheral sensitization, which is driven by sodium channels, leading to central sensitization, which is the calcium voltage-gated channels and the NMD receptor. And then you have, of course, perception and the descending inhibitory pathway. I can give you a drug to block the sodium channels, which is lidocaine and the tricyclics, and so many of the anticonvulsants. I can give you a gabapentin, which blocks the calcium channels, or I can give you methadone, which not only hits the mu receptor, but blocks the NMDA receptor. I can give you an antidepressant, which is going to enhance norepinephrine and serotonin in the central nervous system, which enhances your descending inhibitory pathway. So it's like a Chinese menu, one from column A, one from column B, one from column C, putting them together. Studies have shown lower dose morphine or oxycodone with lower dose gabapentin or nortriptyline works way better for neuropathic pain than either drug alone in a little bit higher dose, and it's safer. So many times in pharmacy, we talk about pick one drug and really maximize it. In pain management, often lower doses of combination drugs is more beneficial for the patient. I do still think acetaminophen is first line. Often we have patients in hospice who are in a long-term care facility who are nonverbal, and they're antsy. They're just antsy. They're maybe a little bit combative. And also just, can we try acetaminophen around the clock? Just let's try, you know, either 3,000 milligrams a day. Let's just schedule it and see if that affects the patient's behavior. Avoid the long-term use of the oral nonsteroidals. I do like the topical nonsteroidals. I do think they're considerably safer, although they've got the same black box warning. And a trial of opioids is appropriate for patients who don't respond and continue to have significant functional impairment, but we don't go lightly into that. Consider the SNRIs. I like the SNRIs. I would pick them, of course, first line if they're depressed and they have neuropathic pain. It's a twofer. It's awesome. Implement a surveillance plan. So we absolutely have to monitor the patient's response to all of these interventions. And I do think physical activity is very important. And I know that can be limiting. It's sort of like the slide you showed that, you know, I feel bad if I don't exercise, and when I exercise, I feel bad. That's true. And sometimes people need an analgesic to be able to do the physical therapy, but eventually the physical therapy will help their pain much, much more. Educate people about safety and efficacy of cognitive, behavioral, and movement-based therapies. Identify local providers. Determine if the goals are being met. If they're not, you should taper and stop the drugs and move on to plan B. Any questions for me? That was a whole hour and a half talk in 30 minutes. Thank you.
All right, we're going to move into our next our panel discussion. So I want to take a minute to introduce one of our new members of our team at the Lamy Center. Some of you in the room may know her. Dr. Zarowitz previously served as a vice president for pharmacy care management at Henry Ford System. She was the vice president and clinical chief officer at Omnicare, and she's been an adjunct professor at the College of Pharmacy and Health Sciences, Wayne State, and University of Michigan. I've worked with her through the years. She's been a mentor and a friend in pharmacy in my career through our work on the pharmacy and therapeutics with Omnicare and that team. And so many of us do know her. And we are excited to bring her on board just recently in the spring as a senior advisor to the Lamy Center. So she's working with our team on grants, clinical programs, and I'll do the shameless plug with our fellowship that we are actively recruiting for. So we're excited to have you moderate the discussion. I'm going to ask all the faculty, we're going to move some seats up here. And at this time, we've got some programmed questions, but we're also going to ask you to ask some questions. What I'm hopeful is that through this discussion, we can identify some potential future work together, and hopefully we've kind of set that stage to go into that. So again, we're going to play musical chairs. I'm going to make sure that we've got the microphones. I'll have Dr. Zarowitz up here asking the team. So if our faculty can just move up. And please don't fall. So let me turn this over for a second. And those of you who are online, I know we've got the chat box as well. So if you want to type in some questions into the chat box, we can do that as well. Great. So I'll get you
Dr.
started.
Brandt,
You got
please
it.
take your seat.
Right in the middle.
That's right.
The rows between the phones.
Thank you all for being here. This is such a great program this morning. And I actually wanted to start by giving you the insights of a gift that I became aware of within the last little bit. Dr. Doberman may know about this, but this book was written in 2017 by Dr. Raina Oddish, who is a pulmonary critical care medicine physician at Henry Ford Health System, who herself ended up in shock and admitted to the ICU. And as the cover indicates, she found herself on the other side of the same partition she was trained to construct, that this author artfully illuminates the dysfunction and the disconnection for everyone involved. It is through her unflinching examination of the fatal flaws, well-intentioned but often misguided standards, that she will be able to achieve for us a crystalline vision of what's different and better possibility for all of us. And there's one paragraph when she was in excruciating pain at one point, and she says, "In that bed in pain, I felt terribly, frighteningly vulnerable, dependent on the care of strangers for my most basic needs as well as my complex care. I felt powerless in a way that is impossible to imagine. From a privileged position of wholeness and well-being, I know this because after this failure, I pathetically tried to ingratiate myself to the team. I believed that I needed to make them like me in order to care for me. I believed I had to earn pain control through good behavior. I felt I had to prove to them that I was deserving." So it's a quick read, and every healthcare professional, I believe, should read it to learn essentially what an abysmally poor job we've all done over the last many, many years. And with the guidance and vision that Dr. Doberman brought forward, my goal, my hope is that we can all do much better. So yes, first of all, you may have questions for the speakers from previously. And in addition, I think I'll pose some that we can all debate and dialogue on together. So let me just start by saying to the group in general, I think we all have responsibilities for educating healthcare professionals in the area of pain management. What were some of your most surprising care myths that you have had to unwind, if you will, or debacle in order to effectively teach healthcare professionals how to manage pain?
Who wants to start? You want to start?
I can't get past my own. And, I think to me, it's really getting, I don't know if it's myths as much as biases. And I think it's getting past those. We all have our favorite drugs. And some of it is if you see something that works, or if you had a bad experience, and we've all had bad experience with the non-steroidals. One drug can send somebody into acute renal failure. They're never off dialysis. That's it. You're never prescribing it again. So I think some of it is more bias and being able to be open. I listened to you about the methadone, and they tried methadone with me, and it was so horrific. I couldn't taste it. I just and psychologically, like, I'm on methadone. I can't even drink a glass of white wine. Seriously? So you have to get past your own bias.
So I mostly teach young physicians. And so especially with the older adult population, it's appropriate dosing. And you don't give the same dose that you would give grandma, that you would give somebody else your age. And then also when you have given 1 milligram intravenous hydromorphone, to somebody, and there is a bad outcome, you don't just avoid the drug, you learn how to redose. And the other thing that I've come across is, I think in our physician training, we see agitated older adults who lack capacity, and we avoid all opioids because we assume that opioids will worsen delirium, or for patients with cognitive impairment who have agitation, that might just be part of their dementia syndrome. And so we don't look for causes of agitation. I was on a palliative team years ago, and the patient was just so agitated. We knew they had a profound delirium. We were all trying to think about it, maybe ordering x-rays. And the chaplain went to lean forward on the bed, and the air mattress that they had deflated, and they had stage 4 wounds. And so we called it diagnosis by chaplain. But common sense. And that was why the agitation, this lady was sitting on the wounds and very painful. So.
If I can say two things to follow up to that. One is I'm constantly amazed at how prescribers don't understand equianalytic dosing of opioids. If a patient's had surgery, they're needing 12 milligrams of IV Dilaudid a day, and they send them home on 5 milligrams of oxycodone a 3 times a day, and then they say, you're a drug seeker. Yes, I am, because this is a lot of pain. And I think I'm most disconcerted in the chronic non-pain arena of what has happened subsequent to the CDC guidance, is that primary care practitioners are saying, that's it, we're not doing pain at all anymore. You need 1 tramadol a day? Too bad, you've got to find a pain specialist. We have 1 pain specialist for every 33,000 Americans. It's one thing if you live in Baltimore. It's another thing if you live in Arp, Oklahoma. Good luck with that.
And I'll piggyback off that. I get the pleasure of training both physicians and nurses and pharmacists, as well as students in the interprofessional team. Some of the myths I've had to overcome is, well, they've been on it for 15 years. How will we ever reevaluate that? How could we potentially reduce the dose? And as you heard Lynn talk about just the changes that happen in terms of how we metabolize and eliminate, it's critical to look at, but also the importance of doing non-pharmacologic tactics and approaches. So I think that's important, you know. The other thing is, well, they're old. I can't change behaviors, right? I can't get them to go and do some of these Tai Chi or other resources, but you really can. And I think it's engaging them, empowering them, making it accessible. And I really am applauding our communities who are stepping to the stage. I did a visit at a YMCA recently. We did a falls program there, and they said, we're actually providing a shuttle to our senior communities so we can get them to the pool, so we can make it easier. So we'll put those bikinis on in the winter. I'm just joking there, Lynn. But in all seriousness, I think we have to be creative when we think about how we partner to make things more accessible, and we can change behaviors. The other thing is, well, they're older. They're not going to divert or abuse those medications. And I think we have to, you know, that kind of, again, not to make everybody suspicious, but I think we do need to be aware of their use patterns, and they may not be abusing it, but unfortunately I've seen their families do. And so we did a program, I know Reba's in the room, we did a program with the medical examiner's office. We did the program with Adult Protective Services, and I was invited to be a part of that esteemed panel. And one of the things that was just impressed upon me is how our older adults are being abused for their pain medicines. And some of the stories I've heard are just horrific. So I think we need to be very aware of not just the way we abuse medicines, but how our elders are being abused for their medicines. So those are my myths.
And I guess I would say I tend to interact with the pharmacy students and our doctoral students. And when I talk to our pharmacy students, I'm tending to talk about substance use disorders. And one of the things that you would think pharmacy students would get off the bat was that, but they don't, is that prescription drugs or prescription opioids are not safe because they're approved by the Food and Drug Administration. That prescription opioids can be the same as heroin or sufentanil or any other illicit substance that you find. And when you start saying that these are the same class, they just don't get it, because they're really, and they get it after they're done with me, but they see as those drugs and the drugs that we use in the care of patients. So it's remembering that there are substances out there, and if a person is not going to be able to obtain pain management, they are going to seek pain management. It might not always be in a medically approved or sanctioned way, and this is something to think about. For my PhD students, one of the things I like to remind them about, because they get so caught up in the statistics and the guidelines and the methods and all the sexy stuff like that, was that actually those data points are people. And just because the CDC says you shouldn't use anything, was it greater than 90 milligram morphine milligram equivalents, doesn't mean that, anything 91 milligram morphine milligram equivalents and higher is bad or suggest abuse or misuse. It's just a response. So when students tend to write up their dissertations or do the research projects, they tend to say these are good and these are bad. But I have to say, no, these are clinical guidelines, and they're only clinical guidelines, and you can't make those judgments. So part of it is understanding that those data points are people, and that when you aggregate those data points, it doesn't necessarily mean that the guidelines that are given are anything but more than guidelines. I'm not sure that makes sense, but that's what
I just wanted to throw out there, particularly when Nikki raised the this substance abuse issue. Many people self-manage pain with alcohol. And I'm going to throw out there, maybe it's not a bad thing. They can self-titrate, and they know what they can handle, and it may work. So I don't know if it's another appropriate option, but in my world, I see that many people do it.
But what's really interesting, in the states where cannabis is legal, there's a 25% less opioid overdose rate. So is that because cannabis is targeting the pain, or they're using cannabis to chemically cope instead of the opioid?
Excellent. And I would just say that now that Maryland has dispensaries out there, it's really important to ask your patients, no matter what age they are, if they come in with a pain condition or a depression condition or anxiety condition, be frank with them and ask, are you using cannabis? Because it can interact with all these medications, including those that we use for pain.
And get your licenses to prescribe.
Green card.
I'm going to shift gears. So CMS's focus on opioid overuse in many ways has been helpful, but as we all have been somewhat critical of it at other times, it can disincentivize clinicians who are really working to try and achieve good pain control, albeit in our seniors, our older adults, our nursing home patients, or others. So what do you see as the most important organizational interventions that could be made to prevent compromising pain management in our patients while still decreasing the risk of propagation of misuse or overuse?
I can take a crack at it. I think that in educating our pharmacy students and nursing and medical and so forth, I think we have an obligation to teach them to be just as skilled at looking at risk mitigation as they are the therapeutics of pain management. And I think the second part of that is then when they are practitioners to document that. So for example, I do like Steve Pasick's model of the 5 A's when you're documenting. So you see a pain patient, you document their level of analgesia, their activities of daily living, their adverse effects, aberrant behavior, and their affect. And to keep your eye on the ball of what is that functional goal and are we meeting it or not. The CDC did not come up with this 50 and 90 milligram thing to be punitive. And certainly we could argue their guidelines all day long. But most people, if an opioid is going to work and improve your functional status, it will probably work before you hit 50 milligrams. So if it does not work by 50, all they're asking is take a step back and say, does this look right? What's cooking here?
I think also from a legislative standpoint, for patients who have Medicaid in the state of Maryland, you have to get prior authorization, and sometimes for each of the Medicaid product lines has a different form for us as NPPAs or docs to fill out, which makes it so exciting to try to figure out which form goes with what patient to fill it out. And of course, nobody comes having still have like 10 pills or 5 pills left so you can fill it out and get the new, that just doesn't work. They've already run out and they're already 2 days in the hole by the time they see you. So I think from a structural standpoint, I know that many other pharmacists that I know are trying to work with the state to try to streamline the processes to make it easier for all patients, but specifically for patients who may have palliative, hospice, or cancer diagnoses. Of course, hospice patients are a little bit different, but clearly comfort care type care plans.
And I think just to piggyback on that, Dr. Doberman, that's a great segue because I think as we developed more quality measures, more kind of aspects of high risk medication, you know, I've worked on the Beers criteria. I cringe because it becomes the good and the bad list, right? But, and so from a payment perspective, so I think when we look at access, so I think there's a couple different avenues. I think there's advocacy and access. I'll follow Lynn's pattern here of the A's. So some of the barriers to access is providers who will provide pain management care and working with our medical groups to ensure that our older adults and those that are vulnerable and frail are not being sent elsewhere, because it becomes, as you said, those guiding principles, treatment burden. I had the privilege of working on that group, treatment burden. And what we don't think about is how much time it takes for that family unit, whether it's that patient and or son or daughter, to go to another consultant, to see another provider, to go to those multitude of visits. You hear about the little black book where there's more dates for providers, but they can't manage that treatment burden. And then they don't show up, and then they get labeled not adherent because they don't make those appointments. But we never think about how much burden that puts on them to do it. So I think coordinated care from our providers and who's going to own the pain management within the access arena. And then from the pharmacy perspective, I'm going to put access and advocacy. Nothing appalls me more when I call our community pharmacies and say, why can't you help this person overcome those barriers? What are the alternatives? How can we work with the doctor? Because turning them away sometimes puts them into acute withdrawal or puts them back into the hospital and the emergency department. So I think there's a lot, but we need to streamline the process. And I do agree. I can't even tell you how many logs that I have for prior authorization portals because everybody has their own portal, their own form. I show up on my days in clinic on Tuesday and Friday to a stack of usually 15. They average anywhere from 3 minutes to 2 hours, depending on what program I need to deal with. It's burdensome, and I know we've talked about that, Barbara and I, with working with the prior authorization departments to look at that unfunded mandate. And I say that because there's a lot of talk on the Hill, and we're not going to get political here, but we need to continue to advocate, because when we talk about protected drug classes, they talk about making, unprotecting the protected drug classes, which gets into a whole nother discussion. So I think we need to, as medical communities, bring our patients when we advocate on a state and national basis, because they listen to them more sometimes than they listen to us, because sometimes they point to us as part of the problem, which has really made me sad in terms of some of our politicians out there. But yeah, so I think there's a lot more work to be done. I also want to say I gotta go back to that suppository on the bench side there. It leaves a kind of a impressive thing upon me, because I'm a pharmacist. I'm proud to be a pharmacist, but we fell in the rankings amongst the most trusted professions. So we went from 2 to 5, down 3 rankings, and nurses are still at the forefront. And I think part of it is the perception of the communities, and part of it is the opioid connection. So, I've talked with others out there, sometimes they perceive we're pushing a product and not a service. So I think it's important when we talk about advocacy that we bring forth the importance of helping our patients navigate this very complex situation. And many of our pharmacists across the country are the most accessible practitioner that's out there. So I just want to put that out there.
One other thing I was going to, sorry.
I have a question. What's being done at a local and state level in terms of advocacy for patients? We all know patients who are on more than 90 milliequivalents of morphine a day, and they've been through everything else, and they do need a higher dose, at least temporarily, for acute, especially acute on chronic pain. What's being done to advocate for that? I feel I'm a nurse practitioner, and many of the pharmacists are afraid of being approached by the DEA or another agency for over-dispensing or misappropriating medication. They have no backup. There's nobody for them to go to. What's being done at the state level to advocate for the pharmacists and the prescribers to say, hey, sometimes a case-by-case basis has to happen, and also looking at the burden on the providers for documenting and doing the prior authorization. Because in my practice, that's taken over completely.
There's more work that needs to be done. I finished a 3-year tenure with national organization, ASCP, which focuses on the post-acute long-term care. We've met with the DEA on a whole host. They are not always easy to talk to. They don't, I know on a state level, I think there's more work, and I'm hoping coming out of this session, we can talk a little bit more collectively on what those barriers are. I know that we just went into session. I think many of us have our upcoming legislative days and visits. And I think collectively, programs like this and partnerships like this need to formalize more. I don't know, Jay, your hand's going up back there, but I think that's what we need to do. And I think, again, there's more coming down in terms of that's going to be burdensome. Oops. Well, I think we had Dr. Magaziner, and then we'll go to you, Dr. Mansour. Can you use your microphone, Dr. Jay? Right in front of you, there's a, sorry.
Okay, so my question, it relates to something I think you started to say. I couldn't hear everything you said, but with the opioid epidemic that has become the big thing that's out there, and all of this worry that we have, and the terrific session today about overprescribing and inappropriately prescribing and careful prescribing. I'm thinking of really the palliative care situation, where it's really long term. What do you think? And I think we sit in a somewhat of an ivory tower, though I know everybody has outreach to the community, especially Dr. McPherson talked about her work out in some of the poorer areas of Baltimore. How is access affected? Because the providers they can get to are not geriatricians, they're not geriatric pharmacists, and they're not palliative care experts. And how are the providers restricting access? They don't want to write prescriptions because they're afraid to. And how are the pharmacies who have to fill these prescriptions staying away from it because they don't want to be dragged into some police case or something else that's happening out there in the world? And I'm not talking about the middle class and upper middle class who have resources, and even though access is not easy, they can navigate. How do we deal with that other situation? Is it really a problem that I'm imagining?
No, you're not imagining at all.
Okay.
I worked for 27 years at University Care Heritage Crossing, and I just retired from that practice last July because the physicians, I saw all the pain patients, and they would sign any prescription I put in front of them. I could write for MS Cotton a million Q12, and they would happily sign it and give me a kiss on the forehead. But if I said, could we discuss this patient? Oh, no. And they have decided, since I decided to leave that practice, they won't do any pain management at all. Even if you need one tramadol a day, you have to go see this pain specialist. And so far as the community pharmacists, I think that their level of scrutiny has certainly heightened. I know Maddie and I were talking about many pharmacies have taken the approach that if you're not a regular patient here, we're not going to fill an opioid prescription. So I brought up the question, what if I'm 20 years old and I don't take any medication, but I had a wisdom tooth pulled? Will you fill my 12 Percocet? And most pharmacies now would say no.
Health point of view, because the emphasis, this is part of the advocacy that you're talking about, Nikki, that it's sort of the other side of it. On the one side, we want to make sure it's done properly. The other side, we want to make sure it's done in the context of the epidemic that everyone is dealing with. And that's really what we hear is the epidemic. But how is that affecting the person who really needs care, who doesn't have the access? Just another piece for the advocacy list.
Well, just to throw in there the long-term care issues as well, where you would think, access is available, but every time, so you have pictured this scenario, somebody's at the end of life, they're really miserable, they're having a hard time breathing, it's a horrible thing to watch, you've got a family member standing there watching that, and I just want to increase the dose of the morphine. I have to go through so many iterations. I have to fill out a form, it's got to get faxed, I can call the pharmacist, but then we have to get approval. And I will tell you that many times nurses put their own license at risk to just go above and beyond. And what I tell families is, write to your senators. I mean, I agree with Nikki, it needs to come from us, the people. And that's the only way it's going to change. And I believe the baby boomers are going to change this damn quick.
I think also the other part of that is when you discharge from hospital to an acute rehab, oftentimes if we write an opioid prescription, the patient has to have the address of the facility on it in order for it to be actualized. But also many times the facilities don't have enough opioid on site for some of the patients who have advanced cancers who are going for rehabilitation. So there's a gap, especially if somebody's on a Duragesic patch, fentanyl, transdermal. There's often a gap of 1 or 2 days until the outside vendor can bring the opioids to the facility. So inadvertently, by all of the safeguards, we leave patients in pain. And one of the other access issues I was going to also talk about is I like methadone a lot too, but not every pharmacy even carries it. So especially in the more rural areas, patients may come into one of the few palliative outpatient clinics, which are usually at the academic centers. They may have their cancer services also same center. But if they go back to fill their prescriptions, those pharmacies may not carry the methadone. And even within some of the more urban centers, not every pharmacy is carrying the methadone or even other high volumes of other opioids. So if you write for Dilaudid tabs, they may not have the full prescription to fill on site.
Yeah, and I would just like to add that if you look at this historically, the issue of pain and its management, we used to be pretty judicious about how we treated pain. For a long time, you could go, before we had the Food and Drug Administration, the FDC, whatever it was, with the Controlled Substances Act, the controlled drug schedules and all that. You know, you could just take a little bit of morphine. Remember Coca-Cola? There's a little cocaine in that, a little stuff in that. So there was very small doses, and people treated themselves for the most part with that. But then as the history of how we started thinking about substance use, then there became a very big suspicion about drugs that were used for pain and almost a prohibition against it. And for a long time, we didn't treat pain well. And then there was one article written, a letter actually, about how pain had been treated in a clinic, and the risk of addiction was very low, if non-existent. And it took off that opioids could be used to treat pain. And so that was the beginning of our evolution of pain as a fifth vital sign. Then, as the problem became evident that there were problems, states started implementing restrictions, prescription drug monitoring programs, and something happened called the chilling effect, and that's what we call it in the field, when prescribers stop prescribing. And we are seeing that now. It's a huge pendulum. And I think you're right. I think the baby boomers will say, hey, you know, we've had enough of this. We want our pain treated. But I think what's happened is that we tend to be very reactive as a nation when it comes to these things. And so getting back to the original question, I think we need to take a very deep and profound look and education of all the people involved in the chain of pain management, from the patient to the prescriber to everyone who's helping, the caretakers and nurses and pharmacists who are helping this patient along, about what it is to treat pain. We don't do that. We don't do it in our medical schools. We do it somewhat in our other schools. I mean, if we didn't have Lynn here, we wouldn't be doing it in the school maybe as much. But at any rate, what I'm saying is that, you know, we really need to take a profound look as a society about what pain is. We need to educate the entire country about what pain is and our expectations about pain, and what they should be. Because life is not a sitcom. It's not like, oh, I don't have, you know, the sitcoms you watch are so ridiculous because kids grow up thinking that you don't have to work, but you have this really nice apartment in Manhattan and your parents aren't there. And if adults are there, Lord, they're just idiots. So, you know, and I think that's the sort of expectation we have in our society about pain. Pain is real. It's part of life.
Dr. Mansour, I know you had a comment.
The question still remains. The pharmacists in the community correspondent responsibility to find painkillers. And what happens often that the pharmacist is put in a situation where they don't have the painkiller. They don't know what's going on with the patient in different stations of care. And then all of a sudden they're presented with a piece of paper that's happened that doesn't have even the symptoms or diagnosis most of the time. And yet they're required to dispense the medication at the gatekeepers of the drug. And so that's where the perception comes to the community pharmacy. And they're put in a line. I have to speak to them. I'm sorry. Oftentimes when decision makers don't incorporate the community pharmacists in the decision making of the prescriptions and the laws and the statutes and everything else, or maybe they're absent, what happens is we see the patient suffer. So open the conversation as to who is the gatekeeper of the drugs, of the medication control. Is the pharmacist represented? I think it's about time, and correct me if I'm wrong, they have collaborative agreements like pharmacists, and with prescribers and the pharmacists, and see who it is in the community that can spearhead this and make everybody on the same page. Just a thought.
Yeah, that's a good point. I know, Barbara, we have some questions online as well that kind of piggyback that. I think, Dr. Resnick, do you have a comment?
Yeah, I was just going to say real quickly, in long-term care, when you write for any drug, you have to write the reason you're giving it. And on a prescription, we don't do that. But maybe our prescription pads need to be a little bit bigger and just articulate the reason why.
Simple as crisp, not in here. Just accessing what's happening before the hospital and
Yeah, I want to piggyback back to both of your comments. Just this year, the IMPACT Act, some of us are familiar with that, is improving documentation and data elements across care transitions. And one of the things that is in that is the indication for use, right? So if you look at your electronic health records, because some of us are writing e-prescribing with controlled substances, there is that domain, but it's not always a forced field. So I think there's a lot more work that we've got the systems, we just don't communicate them. To get back to that. Barbara.
As it relates to our online participants and the IMPACT Act, obviously, what type of MTM services are typically available to hospice patients? And what are your thoughts on the use of narcotic patient prescriber agreement forms and how rigorously these forms should be adhered to the epidemic?
So in hospice, according to CMS guidelines, someone, quote, knowledgeable about drug therapy has to review the medication regimen on admission and then every 2 weeks. They don't even say it has to be a pharmacist. So many hospices will just use the team physician to review the medication regimen, although many do employ a consultant pharmacist. I'm sorry, what was the second part of that?
And then
agreements. I actually 5 years ago had to write a policy for my hospice on suspected drug abuse and diversion in the home hospice environment. We don't routinely get an agreement or do anything like urine drug screens or anything, but we're very mindful of this. So if the patient says, I'm sorry, the dog ate my morphine, we want to see the dead body. We want to see the dead dog. So we're not as naive as we used to be. Hospice used to be very, yeah, I love you, you love me, and we all love Barney. Not so much anymore. So we have a family meeting. We confront the problem. We say, here's what we're going to do. And hopefully just the heightened awareness of, I got my eyeballs on you will be sufficient corrective action. But if not, we go to the next most draconian measure until we get to the point where we say, look, you can either stay in your home and we will care for you, but there will be no controlled substances, or you have to go to a facility if you want to be cared for. And there's no do-over. If you fall off the wagon, we just go to the next more draconian step. End of discussion.
There was another comment from a participant indicating, she agreed with the discussions that Tom and others have raised. There needs to be more work done on the state, county, and local regional levels at offering small group education and conversations to the public at large, along with their healthcare providers. This whole perspective of how we relate to pain, how pain is perceived, how we talk to people about their pain, all needs to be revisited and remove the stigma as well as offer other solutions of non-pharmacologic interventions. We have to move through the prohibition approach to the chilling effect that has sensationalized this whole issue.
Could I speak to
Dr.
something
Doberman.
about just stigma? Because one of the other, we're saying, you know, the pendulum is swinging one way, and pendulums tend to go really far and they finally settle in the middle. One of the other challenges that I see, especially with young providers, PA and doc, is people are trying to not use intravenous modalities for giving pain medicine and trying to use all tablets, but they have not the sensitivity to figure out when an intravenous modality might be appropriate. So in a post-operative patient, you might need to give an IV modality. In patients who have oncologic pain, it might be appropriate to rescue someone by ordering an intravenous modality. And so I think in trying to be very appropriately worried about the opioid epidemic and you know, not order a lot of IVs, especially, you know, quick rush. Are we reactivating things we don't know? We've especially in on the provider side, we've sometimes gone too far. We haven't taught the discrimination of look at the pain pattern. How acute did it come on? How quickly do you need to remediate it? If somebody is about to go down to physical therapy and they swallow that pill, how long is it going to take to be active? Or are they going to come back to their bed and then it's going to kick in?
Did you know Mayo Clinic just decided post-op pain will now be treated with IV acetaminophen?
Right.
Period.
The cost of that's so high.
But no opioids. We just ripped you stem from stern, and we're going to give you some IV Tylenol. Good luck with that.
Before we lose Dr. Resnick, I'd like to pose this question about how, as healthcare practitioners, we also have a research agenda. So how can we quantify the research gap as it relates to what we need to do next? And then how do we begin to address it?
So I don't think we've done a good enough job of describing where we are with pain management and how poorly we're doing, I think, and what some of the issues. And data does help. I think, though, on the Hill, the stories of families are really more effective. But it would be helpful, you know, and I always ask people to try and even quantify, you know, how many times has it happened that you really can't get what you need. We have the stories, but I do think we need more description. Yeah, from families.
The NIH does have considerable resources. Many new announcements. There are many new announcements coming out for palliative care research from the National Institutes of Health, Nursing, Aging, and the Minority Health and Health Disparities Institute all have announcements around palliative care. So there are funds and there are announcements. It may not help you on the Hill today, and I don't think it's one or the other, Barbara. I think we need to be doing both simultaneously, just like the clinician has to provide the best care they know how to provide, given what they know and what they see. But that doesn't mean we stop looking for future applications. So I think there's a lot that can be done with research, and I'm afraid sometimes, being a researcher, not a clinician, sometimes I think we speak more about the clinical issues and less about the research issues, and we need to not necessarily change this discussion about clinical issues at all, but raise the bar on the research issues at the same time. It's not, like I said, it's not one or the other, but we need to, the researchers, and there are many people in the room that are researchers, need to figure out what they can do in that realm as well.
Thank you. Dr. Mcpherson.
I was just going to say, I think that the research in community-based palliative care has been very exciting lately. And personally, I wasn't kidding when I said you should all do my master's degree, because I think everybody needs to be grounded in the principles of palliative care. And I think that's the missing gap right now. I mean, we've got the acute pain, we've got the end-of-life stuff, but it's the community-based palliative care where I think we really need to kick it up a notch.
Yes, comment from the audience, please.
I've never seen it. I remember the IVs.
Yeah, it is. We do it all the time.
being used.
Oh, baby, we put the special in Special K. Oh, yeah. It's, it's interesting how ketamine is being used. You walk into the ER and say, I want to kill myself. They're using it to treat suicidal ideation. We use it for opioid-induced hyperalgesia all the time with very, very good success. I think we're really on the cusp of all this additional research looking at ketamine for depression and for various pain syndromes.
It's starting.
a lot in compounds as well for
So this is an area also where pain clinics are using things on the more cutting edge. There's people using dextromethorphan also as an adjuvant for neuropathic pain. There's people using Namenda also. I can't think of that generic word, sorry. Nimetadine, okay. Also, as neuropathic, a lot of this is coming out of the pain researchers, which tend to be neurology or anesthesia pain, where there is a fellowship after anesthesia in pain management. The challenge is, how do you find a pure pool of people who are all experiencing the same pain syndrome to test if the drug of choice or the modality of choice, such as like a nerve block, is going to work or not work. And I think that's the challenge when you're discussing pain. Pain is personal, right? When you look at the definitions of pain, you say it's a sensory experience. It's what the patient says it is. We can't measure it. There's no vital sign that proves it. And I think some of the challenge is also there's wonderful modalities that we've always called alternative, but really they're complementary. They're integrative modalities. Acupuncture, massage, yoga. We've never investigated how to fully incorporate these. Not every ivory tower has a complementary service. Maryland has wonderful advantage of having the integrative medical line here. Hopkins doesn't have it, just a few feet down the road. Bayview doesn't have it. How can we expand our mind that treating is not just with pills and pumps kind of thing? I think that's the challenge. How do we reach all of America with these different things? Ketamine was at the last hospital I was with, just with the anesthesia pain service. But as soon as patients went, to any of the other pharmacies, they couldn't get their orals filled. They could only fill it on campus.
Yeah, I would just like to piggyback on that, excuse me, because it's all well and good that you have ketamine or something like that, but if you have health insurance and insurance isn't going to pay for it, and that's another big access issue for many of us. We've talked about some of the frustrations on the practitioner level, but on the patient level, it's tremendous. I go to I have a chronic pain with one of my hands, and I go to acupuncture, but my insurance won't cover it. I found a sliding scale place that'll take $20 to $40 a thing, but usually it's about $150. Most people can't even afford the $20 or $40, much less find an acupuncture person wouldn't even know how to start. So I think that when we talk about advocacy and we talk about what can we do, I think one of the things is to start, talking back to the insurance companies and looking at that cycle about why they're making the decisions they are making.
Dr. Whitaker?
So in terms of, current treatment strategies, obviously the headline around right now is about cannabis. And it really didn't impact me, personally in my practice until we had a patient, he came proudly with his cannabis ID card. And I'm thinking, wow, I didn't know you were even on that, for treating pain. So where does that fit in to pain management? Who's eligible, and how do we now incorporate that into practice? Because, again, they don't, need to, it's not that they don't tell you, they need to keep it a secret, but you don't know unless you ask.
It's a freaking red hot mess right now. Because, like, for example, in my practice in hospice, we have to know that they're using cannabis, but we can't put it on the medication history because our physician signs off on that, and it's a C1, so our physician can't actually prescribe it. They can only recommend it. So it's a freaking mess right now. I personally, the Lynn Mcpherson thought is we should make it a C2, and we should be allowed to do research to figure out what's the best formulation for the different pain syndromes and allowed to research it. But it's a mess. It's a big mess.
Yes, please.
Hi, I provide my services at Shepherd Pratt Hospital Geriatric Unit, and our team has come to terms with balancing the risk versus the benefits in pain management to our patients. But I do feel that we are in the middle of this journey, Nikki. So I agree with you that these are patients that have been on it for up to years, and we're all shocked about it. And so the challenges that we have or questions that come to our minds as we're trying to educate the patient, who are actually quite responsive after you tell them the risks, the benefits, here are all your options. First challenge, how did this all get started? Are there people consistently screening for abuse and addictions before making the decision of initiating a particular agent? And then on the other end of this is Medicare does not recognize addictions. Where should I send this patient now who has legitimate pain and is addicted to the substance for therapy like methadone or Suboxone? You know, ethically, I need to put them on that path, but we don't have that many options. Just wanted to get your experience if you are collaborating with others that are screening for addictions before they make this decision, and where else you are referring to patients.
So I'll take a stab at that, Joshna. I think amongst the health systems, when I've talked to some different providers, they do some screening. I don't think it's consistent in terms of the screening and even the assessments. So I think it goes from health system to health system. So there seems to be a bit of a disparity. I think it goes back to some of those myths and perceptions. They may not be screening consistently amongst all cohorts. I'd be intrigued to look amongst the older adults if they're screening and asking those questions consistently. So I think that's step number one within a system. I applaud Shepherd Pratt, and I, as you know, applaud the work you've been doing to try to battle some of these myths and perceptions and tools. I think from an access, this gets back to that access issue, whether it's counseling, whether it's providers who are trained. I've even had some of our NAAA folks feel uncomfortable going to groups because it's younger individuals. So I actually had a student a couple of years ago call around some of the groups to see if they have an age-friendly focus, which is very hard to find. So you're absolutely right. From the training of our providers to the training of our counselors to the tools and support groups that are out there, there's a lot of variability. So I think this is really, it's a huge public need. And again, we don't tend to be focusing on that older adult profile in terms of those access needs. So I don't have a good answer, but I think there's more work to be done. Someone back there does. Yeah.
My question would be, are they addicted or are they just dependent? If they've been on it for that length of time, are they really addicted or is it just dependency?
I think, it's interesting question. I think we can get into that discussion of the behavior aspect and the seeking and what they're putting at risk, right? That keeps, goes over in terms of looking at that. And I think, and that I'm not a counselor or social worker, but I know that's one of the perceptions and myths that families have, that they're going to become addicted. So I think you have to look at their all-encompassing what's going on there. You're absolutely right.
But certainly they're physically dependent.
Yes.
Of course, you can't just stop an opioid suddenly.
Exactly.
But I think even though the FDA turns inside out when you mention this term that's falling out of favor of pseudo-addiction, you take anybody who's on an opioid, and it may not be the best therapy in the world, but they're terrified if you take that away, I'll have nothing.
Right.
And what am I going to do then? Chew on a stick?
Right.
Was there another question?
Yes, I had a comment. I work on a team based in the community, and our social worker has been doing research on this. And I think there's only like 1 or 2 programs in the whole country that are substance abuse directed towards geriatrics. So, and Medicare does not pay for it. So there's no resources out there right now, and that's a huge problem because I see addiction in the geriatric population all the time.
So can you repeat that? And just for the audience that's online, I just want to make sure you heard that. So Shelley's pharmacist based in the community. And again, there's very few national programs focusing on those with older adults with addiction problems, and the reimbursement is not there.
And I just want to comment. I think we have to start training. In med school, I graduated in 2000. We were taught for very little about geriatrics, but what we were taught was all little old ladies drink and they won't tell you. And the second thing is they all are on benzos and they won't tell you. And we learned nothing about old men because they'd all died off and they weren't geriatric. And so,
It's very simple. It's all very simple.
you know, those are the broad generalizations in like the one day of geriatrics. You know, so that's why I did a fellowship, to learn a little more. But I think we have to start at the schools. You know, we have to start at the schools. Some states in the country have mandated that before physicians renew their licenses, they have to do a certain number of CMEs in pain management or understanding about opioids. That's the way you retrofit old doctors, and you teach them new tricks. So I think when we're talking about how do we strategically institutionalize new things, new learning, those are some of the ways that other states have done it. And just that it's not just the opioid epidemic, there's many different things, and do we screen for all of it consistently?
I would just like to add that the Substance Abuse and Mental Health Services Administration does have an increasing interest in older adults. I mean, they've always had an interest, actually, but it's been kind of back burner. They do have these treatment something protocols, TIPs, and number 26 has always been the treatment of substance use disorders in older adults. And it's been, it's in the process of being updated. It might even be out now. I don't know. It's not out yet, but I do know that the old one still has really good information on it if you're interested in substance use disorders and how to identify it, manage it, and refer to treatment for older adults. And the newer one, of course, will be updated probably with new medications. But it is a good resource, and the Substance Abuse and Mental Health Services Administration does have other brochures and good things like that for older adults.
And to piggyback that, she couldn't be here today, but Kim Burton is very involved with working with older adults with both mental illness and substance abuse. And we will post, we did actually reach out to SAMHSA to have them come attend this program. They weren't able to be here, but we are in connection with them too. So when we get updates, we'll post it to the Lamy website with resources for you guys that we'll send out.
So I want to round out the rest of the discussion with one around medication safety. All right, we're dealing with older adults, complex concurrent illnesses, pain management. What are the most significant interventions you may have seen or that you can identify that health systems could implement to mitigate or decrease the risk that older adults will have harmful adverse events related to pain management?
I think it's the brown bag. I mean, I don't think enough primary care doctors know to ask for the brown bag. In residency, I asked somebody if they would bring in all the medicines. She told me her daughter was having her take a lot of vitamins, and she hoped I would streamline it. She came with a wheelie suitcase the next time, and I saw her checking in, and I thought, oh, she's going to the plane afterwards or something. But it literally was like all the vitamins. I said, take everything from the medicine cabinet. It was, of course, expired medicines. I mean, it's all the same stuff we see. She was more than happy to leave most of it behind. And I also do think that in the clinics that I've worked in and on the wards that I've worked in where there are consulting pharmacists, which is not every hospital nor every clinic. I think that, again, interprofessional education and multidisciplinary teams, I think, are some of the best things.
That's why we invited you. So we knew she was going to say that. Thank you, Dr. Doberman. I just want to piggyback on that. I call them medication checkups. So I think, annually everybody should be bringing their meds to being checked up. And I had a woman with 2 bottles of benzos the other day. Thank God we got rid of them. But I think to piggyback that, I think quantity limits, I know that's a blessing and a curse, but I worry when I've seen these pain clinics hand bottles of hundreds of pills to folks and what happens to them. So I know depending on what the indication for pain is, but I think sometimes we're giving too much. But the flip side, and that's why I said it's a double-edged sword, sometimes we're giving too little. So I think, again, getting at that access. But I think those are one things we can look at. I think this is a low-hanging fruit. As we talked about pharmacokinetic changes, many of our adverse effects, because we dose them too high and we don't take into consideration renal dosing, I can't understand why in today's sophisticated age we can't incorporate that more into our point of prescribing. I call it artificial intelligence with prescribing. Why can't we do more of that? And I also think there should be easier alerts. I know we get a lot of alerts, but I think if there could be something that could make me take a pause and say, hey, you know, I don't know if it's the PDMP blaring in red, look at me, and see if the meds are being overused, because trying to find use patterns is sometimes daunting. So those are my 3 things.
So I agree, effective medication reconciliation is critically important, and the most beautiful word in the world is de-prescribing. Look at every medication from the perspective of, can I get rid of this? Not, should I keep it, but can I get rid of it?
And I guess the last thing I would add, I agree with all the above, but also ask your patient what they are taking for pain, mood, general health that isn't prescribed, because that can be important. That might be where you get your marijuana. That might be where you get your St. John's or your CBD oil. You might even get your low-dose naltrexone there, because a lot of people don't think of that as being prescribed. So just ask your patients that.
Fantastic. Dr. Zetterwitz?
Yes, with that, I'd really like to thank our panel for their engagement. I want to echo Dr. Brandt's gratitude to all of you for participating. This was truly a success from our perspective. We hope you feel similarly. Please do take the time to complete the evaluations if you have not already done so, and there'll be someone by to collect them. And with that, ladies and gentlemen, have a wonderful day.
Thank you.